So very good evening, everyone. This is Dr. Singaram. So I hope we can get started with the session if there are no issues with the audio and video and the screen is visible. Okay, right. So in this session, I will take you through the discussion of 25 questions from internal medicine section, which will be important for your upcoming FMG exams. And we all know that medicine is a vast subject, and so I have just tried to take the questions which are priority or most importantly being asked in the exams. Okay, right. So we will try to cover the approach to that particular question as well as some related points of that particular disorder or the topic which we are discussing, which has been asked previously in the exam or which is important for your upcoming exams, right? So that is what will be the plan of discussion. So I would want you to take part in the discussion also. You can put in your comments. I'll be able to see them. If there are any queries also, you can put it and we will take the discussion in a very meaningful way. Okay, right. So let us get started. And before we start, yes. So yes, you can see the screen and we'll get started now. Yes, right. So the first question is from the section of the neurology. It is from the section of neurology. You can see that in your screen also. A 36-year-old woman presents with a 2-day history of fever, stiff neck, and headaches. She also was reported to have had one seizure just prior to her admission. Right. So it is a condition where the patient is having fever along with neck stiffness, headache, and seizure also. Okay, right. So this is the basic information. The patient has a temperature of 39 degrees centigrade, blood pressure of 120 by 80, and a heart rate of 106 beats per minute. A lumbar puncture is performed and her CSF studies reveals the following, right? So you can see that definitely there is some sort of infection which we are suspecting. That is why lumbar puncture is done and CSF studies are being conducted, right? So your entire answer is going to be based on the interpretation of the CSF findings. Okay, first one, protein is 210. Remember, the normal value of protein, okay, right, in the CSF, I'll just write it in the side, is somewhere in the range of around 50 milligram per deciliter. Okay, it is like a range like 40 to 60 like that. So 50 milligram per deciliter, if you take it as a range, 15 milligram per deciliter, definitely the protein level is increased in this particular patient. You can see that. That is number one understanding. Number two, glucose almost in the same range only, like 50 to 70 or 40 to 60. Again, I'll write it as 50 is the normal range. In this patient, 50 to 70. Okay, right. So in this patient, the glucose levels is normal in the CSF. Okay, right. Leukocytes. What is the normal number of cells in the CSF? It is less than 5 cells per cubic millimeter. So definitely the cell count is increased in these patients, and you can see the distribution of these cells. 92% are lymphocytes. 92% are lymphocytes. Only 8% is neutrophils. And you can see RBCs also present. Normally RBCs are not present in the CSF, but RBCs are present in this particular CSF analysis finding, right? So we have a situation of CNS infection or meningitis, which is characterized by high protein, normal glucose, lymphocytic predominance, and RBC presence. What is the most likely diagnosis in this particular condition? Okay. See, meningococcal meningitis is a bacterial meningitis, and pneumococcal meningitis, the last option, is also bacterial meningitis. Are they possible conditions in this particular question? No, they can be ruled out because in both bacterial meningitis, there will be low glucose. Increased protein is okay, low glucose. Along with that, there should be presence of plenty of neutrophils also. Okay, plenty of neutrophils also, right? So that itself will be ruled out in this particular question. Okay, some of you are answering as TB meningitis. What made you think it is TB meningitis? What made you think it is TB meningitis? Some of you might have thought TB meningitis because of increased protein. Okay, right? I do agree. But do you think in TB meningitis, the glucose level will be normal? The glucose level is normal. In TB meningitis, no. In TB meningitis, again you will get low glucose. Again you will get low glucose. Okay, right? See, lymphocytic predominance and protein increase can favor TB meningitis, but there should be low level of glucose in TB meningitis also. That effectively rules out this particular condition also. So what is the answer? Answer for this question is going to be herpes simplex encephalitis only. Okay, herpes simplex encephalitis or meningoencephalitis only will be the answer for this particular question, right? See, most of you must have read like this point. What is that? Herpes or any viral type of meningitis is characterized by normal protein levels, normal glucose levels, and lymphocytes. But I want you to keep in mind that in herpes simplex encephalitis or meningoencephalitis, protein levels can be increased also. Just because protein is increased, don't rule out herpes infection. That is what I am trying to say. And also, normal glucose is something which is very, very favorable for viral infection only. So that was the main clue in this question. And the answer for our question is option B, herpes simplex encephalitis. I hope you're able to follow this and your confusion with TB meningitis is now solved. Okay. Every year after exam, I see some question somewhere they're related to CSF analysis findings. So you should be knowing about this very, very correctly for your exam purpose, right? I think that part is clear. Answer is option B for this particular question. Now, a few points I want you to answer quickly. HSV encephalitis, right? That is the topic we are talking about. Now, HSV has two types, HSV1 or HSV2 causes encephalitis. It is always HSV1 which causes this encephalitis, right? Because HSV2 is for genital lesions, right? Sexually transmitted disease, right? So HSV1 is the one which is for CNS infection. Okay. Now, tell me, area of predilection or target area in the brain. Any idea what is the target area in the brain? In case of HSV infection, very, very important. The target area is the temporal lobe. Okay, temporal lobe. It is temporal lobe. Very important point. So please keep a note of this. Okay, target area inside the brain is temporal lobe. That is why when temporal lobe is affected or only one part of the brain is affected, what type of seizures they usually develop? What type of seizures they usually develop? Do they develop generalized seizures or focal seizures? Answer this, generalized seizures or focal seizure. What type of seizures they develop? They develop focal seizures because only one part of the brain is affected. Okay, so they develop focal seizure, right? So this is something which you need to remember. Type of seizure is focal seizures. Okay, right. Then what is the characteristic EEG finding in case of HSV1 encephalitis? And if you know about this, characteristic EEG finding in HSV1 encephalitis, EEG finding. The EEG finding is yet another important term which you should be knowing for exam purpose. It's a one-liner question. It's called PLED. What is expansion for that? It is periodic lateralizing epileptiform discharge. Periodic lateralizing epileptiform discharge. This is what you need to remember. Okay, the name of this finding. PLED. Periodic lateralizing epileptiform discharge. So please keep a note of this. It's a very important EG finding. Okay, right. Now tell me, more like a microbiology question, but you can answer it. What is the investigation of choice to diagnose HSV1 infection? What is the investigation of choice? Any answer? What is the investigation of choice? It is PCR testing. You have to do in the CSF PCR testing. That is supposed to be the investigation of choice. Please don't forget this. It's a PYQ also. Okay, for HSV infection, it is PCR testing in the CSF to diagnose the meningoencephalitis. Okay, now tell me, what is the drug of choice for treatment of this condition? What is the drug of choice for treatment of this condition? Definitely, it is going to be antiviral in the form of acyclovir, and because it's a CNS infection, will you give it orally or intravenously? You have to give it intravenous acyclovir. Intravenous acyclovir. These are some additional points about HSV encephalitis that you need to know about. Okay, right? Treatment is IV acyclovir. Okay, right. Now, you have studied the CSF analysis, right? But there was something which was additionally given in that particular question. What was that? What was given in the question? Yes, RBCs are present. RBCs were present in the CSF. RBCs means what? Blood is present in the CSF. Okay, so basically blood was there in the CSF of this particular patient. And please remember, HSV infection is one condition which can be associated with bloody CSF. Okay, blood in the CSF. One of the differential possibilities is HSV1 infection. HSV1 meningoencephalitis. Very important point. Meningoencephalitis, keep this in mind. It's a special finding which I want you to remember. Can any of you tell me any other condition where blood in the CSF can be present? Any other condition where blood in CSF can be present? Yes, of course, if you are not doing the lumbar puncture properly and it injures some blood vessel, then also blood can enter in the CSF. Or traumatic tapping. That means while doing the procedure, you're causing trauma, that itself can cause blood in the CSF. Number 3 is very important from an exam point of view. I'm putting a star for that. It is one of the conditions characterized by bleeding. Very good. Some of you already answered it. It is SAH. What is SAH? Subarachnoid hemorrhage. Okay, because basically, where are we taking the CSF from? We are taking the CSF from the subarachnoid space only. If there is a bleeding in the subarachnoid space, obviously you will get blood in the CSF also, right? So subarachnoid hemorrhage is also characterized by bloody tap, right? That is what you need to remember. So all these are 3 important conditions where you can expect blood and RBCs in the CSF. Please make a note of this. Okay, right. I told you temporal lobe is the main lobe affected in case of HSV infection. Can anybody tell me for other areas of predilection in case of other viral infection? For example, Japanese encephalitis. Any of you know what is the site of involvement for Japanese encephalitis? What is the area of brain that is affected? This is yet another important question. Japanese encephalitis, please remember, is the most common cause of virus associated meningitis in India. Very important. In India, the most common cause of viral meningitis is JE. See, HSV is common worldwide, no doubt about it. But in India, the most common cause of viral meningitis is Japanese encephalitis only. Any of you know what is the area of predilection? Okay, it is basal ganglia and thalamus. Please make a note of this. It is basal ganglia and thalamus. They are the site of predilection. Okay, how they typically give it in your exam? They give it like this. You are evaluating a patient who is having fever, seizure, meningoencephalitis like that. MRI reveals lesions in these areas like that. And then they will frame the question, what is the organism responsible for that? That is how they are going to frame the question. Okay, right? So please keep that in mind. Okay, so Japanese encephalitis is this one. CMV doesn't have any one particular area, but it causes inflammation of the ventricles, lateral ventricles, third ventricles, and fourth ventricles. So that is why characteristic for CMV infection is ventriculitis, inflammation of the ventricles, ventriculitis. That's a keyword which we associate for CMV infection. Okay, right? So based on all these discussions, anyway, for our question, the answer was very clear. It was herpes simplex encephalitis, right? Quickly recollect, even though protein was elevated, still it was viral infection only, because what was favoring the viral meningitis? It was 2 things. Number 1 is normal glucose. Number 2 was lymphocytic cells present in the CSF analysis, right? So that is why the clear answer for our question is option B only, right? So that is the question number 1, which is now completed. We move on to the question number 2. Which of the following conditions is associated with ipsilateral loss of pain and temperature sensations in the face and contralateral loss of pain and temperature in the body below the face? Which of the following condition associated with that? You have the options in the form of Wallenberg syndrome, Claudy syndrome, Horner syndrome, Ramsay-Hunt syndrome. Anybody wants to give a comment on this based on the question? I'll give you a few seconds to think about it. Anybody wants to give an answer? Okay, fine. See, let us analyze the options. Okay, right? Let us analyze the options. See, it is nothing but loss of pain and temperature means sensations are lost. Sensory loss in the same side of the face. And below the face, that is in the body, there is a contralateral loss of sensation. That is what this question is basically asking about. Which of the 4 syndromes fit into that? It is very, very clear case of Wallenberg syndrome. It's a very, very clear case of Wallenberg syndrome. I think some of you have answered it, and one of you have answered a different option also. I'll come to that. Okay, this is Wallenberg syndrome. We'll just do a quick recap of the Wallenberg syndrome. See, what is Wallenberg syndrome? It is basically something which is related to medulla, lateral medulla, correct? That is why it's also called as lateral medullary syndrome, which is a form of stroke due to occlusion of which artery? It is due to occlusion of which artery? Occlusion of which artery? It is pica, posterior-inferior cerebellar artery, more than vertebral artery. Very important point. If both options are given also, pica occlusion is what we need to remember. Okay, right? Pica occlusion is what we need to remember as the most common cause of Wallenberg syndrome. Okay. Now what happens is the lateral part of medulla. Okay, the lateral part of medulla has, just a minute, the lateral part of medulla has the nucleus related to the trigeminal nerve. Okay, has a nucleus related to trigeminal nerve, that too sensory part of trigeminal nerve. That is why you can see there is ipsilateral loss of pain and temperature in the same side of the face. This is due to trigeminal nucleus, sensory nucleus getting affected. That is the reason. Okay, fine. Now, it also has got spinothalamic tract. Lateral medulla also has got the ascending spinothalamic tract, but that spinothalamic tract carries sensation from the body on the opposite side, because spinothalamic tract is a crossed tract once it enters the medulla, right? Because it's a crossed tract, spinothalamic tract, you are getting loss of pain and temperature from the opposite side of the body below the feet. Okay, right? This is what you need to remember. And we call this by a name. What is that? Same side face sensations are lost, opposite side body sensations are lost. This is called crossed sensory loss. Very important. This is called as crossed sensory loss. And this crossed sensory loss is supposed to be the hallmark feature of Wallenberg syndrome also. Please be aware of this name. It is called crossed sensory loss. Okay, right? Are you able to follow this? Fine. We have already seen one point, that is cross sensory loss. Now we need to know what are the other features of this particular condition, right? I think you should be able to remember from what you have already learned. We'll do a quick recap of that. They can have involvement of the cranial nerve nucleus, like nucleus ambiguous, which is concerned with 9th and 10th cranial nerves. That is going to result in dysphagia and hoarseness. Next is the vestibulocochlear nerve or the 8th cranial nerve getting affected. That is going to result in vertigo. And also few cases can have involvement of sympathetic fibers resulting in Horner's syndrome as well. Remember, Horner's syndrome is not the primary diagnosis, it is lateral medullary syndrome or Wallenberg syndrome only. A feature can be Horner's syndrome. That is what I'm trying to say. Okay, are you able to follow this? Right. So now our clear answer for the question is nothing but Wallenberg syndrome only, right? But just to tell you how other options are ruled out. See, Claudy syndrome, it is something related to midbrain. Okay, it's something related to midbrain. Something related to midbrain. And tell me, what are the features of Claudy syndrome that comes to your mind? What are the features of Claudy syndrome that comes to your mind? Yes, it is ipsilateral third cranial nerve palsy. Along with that, any other finding? Any other finding for Claudy syndrome? Ipsilateral third cranial nerve palsy. Along with that, no, doctor, you're wrong. Vertebral artery is the second implicated artery. Okay, right? Pica is the most commonly implicated artery for Wallenberg syndrome. Okay, right? Anybody? Just 1 second. You can type in your answer. Just give me a second. 1 minute. Yeah, 1 minute. The comment section was not visible, so that is why I'm just looking. Yeah, now I can see. Yeah, correct. It is also associated with red nucleus involvement in the midbrain, due to which what happens is there is a contralateral ataxia feature also is noted. That is what is Claudy syndrome. Okay, right? That is what is Claudy syndrome. Okay, right? Very important. Okay, right? This is something which you need to remember. Horner syndrome is characterized by 3 features. What are the 3 features? Ptosis, meiosis, and anhydrosis on one side. So that is anyway not given in the question, that is also ruled out. And some of you were saying this as the answer. What was that? Ramsay-Hunt syndrome, the last option. That is not the answer for this question, but just to give you some brief idea about Ramsay-Hunt syndrome. Okay, it is something related to which virus? It is something related to the herpes zoster virus. You all know about it, right? It's something related to the herpes zoster virus. Okay, this is what is the Ramsay-Hunt syndrome. It's a herpes zoster oticus. That is what we remember. Okay, right? Herpes zoster virus. Involvement, something near to the ears, that is why it's called oticus. It is basically an outbreak of the virus only, right? Like the shingles only, right? But it is something related to the facial nerve, and that too related to the ear region, right? That is why the features are going to occur in this condition. It is basically reactivation condition. It is basically a reactivation of the herpes zoster in a patient. Okay, it's basically a reactivation of herpes zoster. That is what I'm trying to say. Oticus tells you it is something related to the ear region, and facial nerve is getting affected. That is why, can you see the triad of features in this condition? That is why you can see the triad of features in this condition. What are the triad of features? Number one, facial nerve palsy, characterized by drooping of the mouth in that area, you are able to see. Second, because the ears are affected, you get severe ear pain or otalgia. Third is, you all know that herpes infection is characterized by blisters or vesicles, which is also seen in and around the ear. That is the third part of the triad in case of Ramsay-Hunt syndrome. Can you see that in your screen? You have the three features, the triad of features of Ramsay-Hunt syndrome. That is anyway not given in the question, so that is also ruled out. So the clear answer for question number 2 is Wallenberg syndrome. I hope you're able to follow this, everyone. It is Wallenberg syndrome. Okay, right? So that's about it. Question number 2 is done. Moving on to our third question. Yes. A 27-year-old woman presents with fatigue and double vision. Okay, right? Double vision is nothing but diplopia. Okay, double vision is nothing but diplopia. Fine. The patient reports that these symptoms occur at the end of a long work day. That means in the evening, the patient is having worsening of the symptoms. It's a female having fatigue, diplopia, which is worse in the evening. The patient also reports that she does not eat tough foods, like for example, solid foods like that, because it is difficult for her to chew properly. Okay, right? Possibly, maybe due to jaw muscles getting affected. Jaw muscles getting affected. That is why she is having difficulty in eating solid foods. Probably some sort of jaw muscle getting affected. Neurological examination is otherwise normal, and the patient has normal creatinine kinase levels also. Creatinine kinase levels are an indicator of muscle damage, or what they are saying is it is not primarily a muscle problem. That is what they are trying to say. And very, very important clue is given that tensilon test is positive. I think all of you know about this. Tensilon test is a test which is done in patients with muscle weakness, where we give tensilon or the short-acting acetylcholinesterase inhibitor. What is that? Edrophonium, and we look for a response. Okay, tensilon test positive means after giving edrophonium, there is an improvement in the muscle weakness. There is an improvement in muscle weakness. Improvement in muscle weakness. That is what tensilon test positive means. So now you can have so many clues in the question. It's a middle-aged female having diplopia and muscle weakness, which is worse in the evening, and the tensilon test is positive. I don't think you require more clues. What is the diagnosis? Here it is myasthenia gravis, right? No doubt about it. It's a clear case of myasthenia gravis only. Now the question is, what should be the best initial imaging test in managing the patient's condition? Remember, the question is not any other test, imaging. Imaging means something related to radiology testing. They are asking MRI of the head or MRI of the brain, CT scan of the chest, CT scan of the abdomen, or ultrasound of the neck. Which will you do for this particular patient? Anybody? Which will you do for this particular patient? See, you are not going to do any brain testing. Brain testing will not reveal any abnormality. But you should remember, myasthenia gravis has an important association in the form of something related to the mediastinum. What is that? Thymoma. Very good. It is something related to the thymoma. Okay, thymoma. Okay, thymoma or a thymic tumor. So now tell me, if it is thymoma, what is the investigation I can do to pick up the possibility? Okay, to pick up the possibility. Thymoma. Some of you are saying ultrasound of the chest can be done. Compared to ultrasound, you don't think thymoma as only neck region. Neck is not for thymus. Thymus is something related to mediastinum, doctors. Thymus related to mediastinum. So if it is mediastinum, what should be the investigation that I have to do? Okay, anterior mediastinum only. It is there in the anterior mediastinum. Okay, anterior mediastinum. If it is anterior mediastinal tumor, the best test would be CT scan of the chest, not ultrasound of the neck. It is CT scan of the chest would be the best investigation, imaging investigation to do for this particular patient. I hope you got the idea correctly. Are you able to follow, everyone? Okay, right. Now let us see some quick points about this myasthenia gravis. What is the initial test I can do for this patient? Okay, leave that imaging testing. Okay, right. We all know myasthenia gravis is an autoimmune condition. What is the best initial test I can do for this patient? I can look for antibodies. See, the question is already done. Imaging test means it is CT of the chest. That is over. I am asking patient with myasthenia gravis, what is the initial test to look for antibodies, and that too acetylcholine receptor antibody, which is in short form remembered as anti ACHR, that is anti-acetylcholine receptor antibody, will be the best initial test I can do. Tell me one more, which is going to be the most accurate test for diagnosis of this condition? Most accurate test for diagnosis of this condition. You have to do something called EMG. What is EMG? Electromyogram is supposed to be the most accurate test for this condition. What we will do is, we will do something called repetitive nerve stimulation. We'll do something called repetitive nerve stimulation, and then we will look for the response. We'll look for the response. Can you see? This is the picture explaining that repetitive nerve stimulation. What we do is we give repeatedly stimulation of the nerves and look for response in the muscle. Can you see that in a normal person, this is normal person. In a normal person, every time you do a nerve stimulation, there will be the same muscle response which will be noted every time. That is why you can see the curves are the same intensity. But in case of myasthenia gravis, MG stands for myasthenia gravis. What is happening? The intensity of the response keeps on decreasing. Can you see that? Every time you give it subsequently, the intensity of the muscle response will be decreasing, not maintained throughout. This is what we call decremental response. This is what is called decremental response. And this decremental response is supposed to be hallmark feature of myasthenia gravis. It's a very, very important MCQ question which you should be knowing about. Okay, right? It is decremental response. Okay, right? So remember, best initial test is looking for antibodies. Best accurate test or the diagnostic test is electromyogram. If the question specifically asks you what is the imaging test, then only you have to say the answer is CT scan of the chest, because CT scan of the chest will help you to determine the presence of thymoma in this condition. And you all know that if thymoma is present, you have to do thymectomy as a part of treatment in case of myasthenia gravis also. For that reason also, knowing this fact is very important. Are you able to follow this? Right. So that's about question number 3, which is now completed. Moving on to the next question. Have a look at the question. It's a picture based question. Yes, have a look at the question. A 54-year-old man has a history of hypertension, develops weakness affecting the left face, left arm, as well as left leg. Okay, right? Non-contrast CT brain reveals the following finding. What are you able to see in the picture? Basically, hypertension risk factor is there, and he is having what? He is having one side face, arm and leg weakness. That means he is having unilateral, not unilateral, one side limb weakness. What is that? Hemiparesis. He is having hemiparesis. That is what? Limbs are showing weakness. That is what is called hemiparesis. Or in other words, this patient is developing stroke. Okay, this patient is developing stroke. And for a patient with stroke, we will always do the non-contrast CT as the initial imaging modality. And what you are able to see in that picture, you are able to see something very striking. What is that? What is this finding? It is something which is whitish in color that represents the bleeding. That represents the bleeding in that particular patient. Okay, right? It is representing the bleeding. That means we are having a patient who is having bleeding and resulting in stroke, or in other words, hemorrhagic stroke. The patient is having hemorrhagic stroke. We all know there are two types of stroke. One is ischemic stroke, second is hemorrhagic stroke. This patient is having hemorrhagic stroke. Okay, that part is clear. The question is asking, which of the following is not used in the management of this patient? Okay, blood pressure control, osmotherapy with mannitol, altiplase therapy, head elevation, airway protection, head elevation and airway protection, right? Which one is not used in the management of this condition? That is what is the question. Basically, in hemorrhagic stroke, okay, right? See, this patient was having hypertension. So, definitely blood pressure control is indicated in the part of management. Due to bleeding, what is going to happen is there will be increased intracranial tension. So, we need to decrease intracranial tension. Osmotherapy with mannitol definitely will decrease the intracranial tension and will be helpful in the management of this condition. So, that cannot be the answer for the question. Look at the next option. What is that? Altiplase therapy. Altiplase therapy means it is thrombolytic therapy. Thrombolytic therapy. Thrombolytic therapy is for which type of stroke? It is only for ischemic stroke. It is only for ischemic stroke. It should never be used in hemorrhagic stroke. In hemorrhagic stroke, if you use thrombolytic, what is going to happen? More hemorrhage is going to happen, right? So definitely thrombolytics are avoided in case of hemorrhagic stroke. That is a clear answer for this question also, right? See, head end elevation also is supposed to have an important role in decreasing the intracranial tension only. Of course, airway protection is definitely required, okay, right? For these patients with stroke or any neurological emergency, airway protection is always a must, right? So, head end elevation also will decrease the hemorrhagic, will decrease the intracranial tension and thereby helping in the management of this condition. Okay, right. I hope you're able to follow this. So, anyway, because this condition is hemorrhagic stroke, thrombolytic therapy is actually contraindicated, and that would be the answer for this particular question. Okay, right. Now, I want you to know something very, very important for your exam purpose. Okay, right? Very, very important for your exam purpose, and that is something related to something new management guidelines in stroke. New management guidelines in stroke. Three things I want you to remember very, very clearly. I think one of that you have already learnt it in your previous discussion itself. Two will be new for you, so please make a note of it. Number one, when a patient with stroke comes to the hospital, you are definitely going to do non-contrast CT, right? No doubt about it. Okay, non-contrast CT, and the timeline which is given is 20 minutes. Within 20 minutes of patient coming to the hospital, you should have done the non-contrast CT. Very, very important first point. Okay, that is why it is written, do it fast. That is the first important point you need to remember. Number 2 point you need to remember is, if it is a patient who is having ischemic stroke, I just told you, you have to start thrombolytics. Thrombolytics will be like altiplase or tenecteplase, but what is the timeline for that? Within 4.5 hours of onset of symptoms, you have to give thrombolytic therapy in case it's a ischemic stroke, right? I think this point you have already learned and it is already asked in the exams also. Third important point, look at it, very important. It is very new also. The new point is, if a patient is having only minor non-disabling stroke, what is the meaning of that? He is not having any limb weakness. He is having only a small facial deviation, which is no way affecting his daily activity. That is what is the meaning of non-disabling stroke. Non-disabling stroke basically means only a minor inconvenience is caused to the patient, not major inconveniences. For that patient, what they are saying is, you don't need to give thrombolytic therapy. You can give something called DAPT. What is DAPT? Dual antiplatelet therapy is required. Dual antiplatelet therapy alone is required. Don't give thrombolytics for the patient. Dual means two drugs. What are the two drugs? Number one is aspirin. Number two is clopidogrel. These are the two drugs for dual antiplatelet therapy, and that is only for a patient with minor disabling, non-disabling stroke, right? That is what you need to remember, right? Okay. I think these are three important points, something related to new updates, which I want you to know for your exam purpose, going to be very helpful for the upcoming exam, right? So do make a note of this. That's it. So that is about a question related to stroke. We move on to the fifth question. A 65-year-old female complains of severe headache on the right side. Okay, right? Severe headache on the right side and poor vision for the last 2 days. On examination, there is a thick cord-like structure on the right forehead area. Investigation reveal elevated ESR. What is the likely diagnosis? That is what is the question. We have the options in the form of migraine, cluster headache, sinusitis, temporal arteritis. What do you think is the answer for this question? All four options given in the question can be associated with headache, no doubt about it. Okay, but which one for this particular patient? Okay, let us start. See, one important clue is not just headache, the patient is also having poor vision, vision disturbances. And also, one more important clue given is a thick cord like structure on the right forehead area. Forehead means this area, the frontal area. There is a thick cord like structure which is noted. Now, think about it. Think about it. Which one is going to be possible? Okay, we have four options. Number one option is migraine. Do you think in migraine the patient will have a thick cord like structure? No. Migraine is like a one side face full headache, long duration headache, as well as the patient will have a very, repeated episodes of headache, and it's a female patient, and that too, not very old female, like middle-aged females is what we usually think about, right? So, migraine is unlikely as a diagnosis for this question. Cluster headache. Where is the location of headache in cluster headache? It is something periorbital. It should be given very clearly, okay, right? Periorbital headache. It's a very severe form of headache, more common in males compared to females. And in cluster headache also, do you think there is a thick cord-like structure which is noted? No, it is not noted, so that is also ruled out. Sinusitis, no way is in the question. Sinusitis is not going to be associated with a poor vision commonly or a thick cord-like structure. So all that is ruled out. The clear answer for our question is the last option only. What is that? Temporal arteritis, also called the giant cell arteritis. Correct? Temporal arteritis, also called the giant cell arteritis. It's a type of vasculitis only. Tell me, what is the type of vasculitis? Is it a medium vessel, large vessel, or a small vessel vasculitis? Definitely, this is a large vessel vasculitis. No doubt about it. This is a large vessel vasculitis. It affects multiple arteries, okay, right? Carotid arteries, vertebral arteries, okay, right? Basically, the arteries arising from the aorta branches, okay, right? That is what we are talking about. But it's a large vessel vasculitis, okay, right? And one of the artery affected is the temporal artery itself. That's why it gets the name temporal arteritis. And that inflamed temporal arteritis is what is noticeable in the patient as a palpable cord-like structure. Very important. Palpable cord-like structure, which was an important clue given in the question. And not only that, because it is vasculitis or inflammation, what will happen to the ESR? ESR is always elevated, which was also given in the question, right? So anyway, the clear answer favoring this particular question was temporal arteritis only, with all the points I have told you. Just quickly telling you some important things or additional points which you should know about. Okay, one question. Let me just see if I have that slide, or I will explain it here itself. Just a minute. Okay, fine. I'll go back to this slide itself. Tell me, what is the reason for visual disturbance in this patient? Anybody? What is the reason for visual disturbances in this patient? Anybody wants to say? Why vision should get affected? I do agree, this temporal artery, so headache, all those things are okay. Why vision? Why vision is affected in this patient? Why vision is affected in this patient? Okay, one important artery which can be affected in this particular patient is posterior ciliary artery. Okay, posterior ciliary artery. Please keep in mind, posterior ciliary artery can be affected in this particular condition. Now, this posterior ciliary artery is actually a branch of ophthalmic artery. Very important. Okay, right? It's a branch of ophthalmic artery, which itself is derived from the carotid artery only, right? And that carotid artery can be affected in case of this temporal arteritis also. And because of this posterior ciliary artery occlusion, it leads on to something called AION. What is that? Anterior ischemic optic neuropathy. Anterior ischemic optic neuropathy. Okay, anterior ischemic optic neuropathy, which is the cause for vision abnormalities in this particular patient. Very, very important point. So please do make a note of this. Okay, right? Why vision problems are noted in this particular condition of temporal arteritis. I hope that point is clear, everyone. Okay, right? So I have just tried to explain to you the features of temporal arteritis. Now tell me the answer for this. What is the most accurate test to diagnose this condition? Anybody? Most accurate test to diagnose this condition? Any answer? Straightforward answer. Yes, you have to do the biopsy of the temporal artery to show that there is evidence of vasculitis. So, temporal artery biopsy is supposed to be the investigation of choice. Temporal artery biopsy is supposed to be the investigation of choice. Yes. Can anybody tell me what is the best initial treatment I can give for this patient? Best initial treatment I can give for this patient to control the vasculitis? It is always steroids, and prednisolone is supposed to be the answer. High dose prednisolone will be the investigation for this particular will be the treatment for this particular condition. High dose prednisolone. Are you able to follow this, right? Yes. So that was about this particular question. The clear answer or the cause of headache in this patient is nothing but temporal arteritis. That's it. Okay. So that was question number 5, which is done. Moving on to the question number 6. Yes. Look at the screen. It's a case scenario question. A 42-year-old male is brought to the clinic by his wife due to increasing irritability and several episodes of uncharacteristic emotional outburst over the past 6 months. So basically he is having some behavioral problems. That is what I am trying to say. Okay, right? Emotional outburst, irritability, all this tells you some sort of behavioral abnormalities in that patient. On examination, the physician observes brief, jerky, non-repetitive movements of the fingers and the toes also. The patient gait appears slightly dance-like gait. Okay, what is the meaning of this? Some movement of the fingers, abnormal movement of the fingers, along with a dance-like movement of the gait. What does it tell you? It is nothing but chorea manifestation is also noted in this particular patient. Okay, right? Chorea manifestation is also noted in this patient. During the history, while you are taking history from the patient mentions that his father developed similar behavioral changes and motor issues in his late 50s before passing away in a long-term care facility. That means there is a significant family history also present. Family history of significant illness, similar illness is also present in that particular patient. So we have a condition characterized by chorea, some sort of emotional or behavioral problems. Along with that, it's a family history positive, meaning it's an inherited condition. Okay, now the question is, which is not true about this patient's condition? Chorea, mood abnormalities, early onset memory loss, brain imaging is likely to show abnormalities of caudate nucleus and putamen. Okay. First and foremost thing, you tell me from the case presentation I had given, what is the diagnosis? What is the diagnosis? Inherited condition characterized by chorea as well as some emotional or behavioral problems. Very correct. It is a case of Huntington's disease or Huntington's chorea. Okay, it's a case of Huntington disease or Huntington's chorea. And you should tell me what is the basic pathology in case of Huntington's disease. Please remember, it's an autosomal dominant disorder. Okay, due to a gene defect, something called Huntington's gene defect located on chromosome number 4. Very important, located on the chromosome number 4. Okay, Huntington gene located on the chromosome number 4. And this condition is characterized by something called trinucleotide repeat disorder. Trinucleotide repeats. And what is the trinucleotide repeat in this condition? It is CAG. Trinucleotide repeat is noted. And this CAG trinucleotide repeats is going to cause damage to some part of the brain. Okay, which part of the brain? It is going to cause damage to the caudate nucleus and putamen. Okay, caudate nucleus and the putamen. Okay, right? Caudate nucleus and the putamen. And that caudate nucleus and putamen is nothing but the basal ganglia only. So damage to that basal ganglia is going to result in the chorea-like manifestations in this particular condition. Okay, chorea-like manifestation in this particular condition. Okay, right? And this condition is characterized by some characteristic clinical features which are typically remembered as 3 M's. What are the 3 M's you need to remember? One of the M is motor problems. One of the M is motor problems. Okay, the motor problems, initially they will have hyperkinesia. That means increased motor activity, but not normal activity, abnormal motor activity like chorea, athetosis, like that initially. Then what happens is later they will have hypokinesia, meaning decreased motor activities like rigidity and all can be noted. Rigidity and all can be noted. And the characteristic rigidity is a cog wheel rigidity which can be noted. Okay, so initially they can have hyperkinesia followed by hypokinesia. That is one of the M. Second M is nothing but the mood disturbances. Mood disturbances. They can have extreme irritability, depression, psychosis. So many of these patients, they end up in psychiatric consultation also, right? That is something which you need to remember. Third M, tell me, what is the third M in Huntington disease? It is memory disturbances. It is memory disturbances. But an important point I want you to remember here is the memory loss which occurs in Huntington disease is not an early feature. It is a late feature. Very important point. It is a late feature. Why late feature? You have studied other conditions with memory loss like Alzheimer's disease. Okay, where amnesia or memory loss is an early feature. But for Huntington disease, I am saying it's a late feature. Why? Because Huntington disease is a subcortical dementia. Very important point. Subcortical dementia always has memory loss late in the disease only. Whereas if you see Alzheimer's disease, I'll just make a note. Alzheimer's disease is a cortical dementia. Alzheimer's disease is cortical dementia where the patients will have early memory loss. Okay, where memory loss is an early feature. Memory loss is a early feature. Are you able to follow? Whereas Huntington disease, it's a subcortical dementia where memory loss is a late feature. This point you should clearly know about. Okay, this point you should clearly know about. I hope you're able to follow this. Based on this discussion, the answer for our question is option C only. Why? Option C says that early onset memory loss, it is not a feature of Huntington's chorea, right? It's a late onset memory loss. Chorea, mood disturbances, brain imaging showing problems in caudate nucleus putamen, all are true for Huntington disease only, right? So, clear answer for our question is option C, which is early onset memory loss is not a feature of Huntington disease, right? So, that should be kept in mind. I hope you're able to follow this, everyone. Yes. Okay, fine. Now, moving on to the next question, question number 7. Question number 7. Yes. A 30-year-old patient has a history of jaundice for last 2 weeks. Okay. Liver function test reveals elevated bilirubin and elevated SGOT and SGPT, that is the liver enzymes. He is positive for HBs aging. Hepatitis B surface antigen is positive. What should be the confirmatory test to establish acute hepatitis B infection in this particular patient? The key word here is acute hepatitis B infection. Have a look at the options. Just quickly type in your answers. Just give me a few seconds. I'll be back. Type in your answers. Okay, I can see some options. I can see some answers. Yeah, some of you are answering as option A, some of you are answering as option C, some of you are answering as option D as well, right? See, this is a very straightforward question. Always remember, hepatitis B is one of the topics which is given lot of importance in the exams. I think you should be knowing about this. Hepatitis B is a extremely important topic for your exams. Okay, the question is asking, we have some evidence that this patient is having hepatitis B infection. Which test will establish the diagnosis of acute hepatitis B? See, in acute, what type of antibody will be positive? Obviously, IgM antibody will be positive. So, presence of IgM anti-HBC antibody will establish our diagnosis of acute hepatitis B infection. Okay, very clear. Okay, now tell me one thing. If HB, okay, look at the other option, right? I'm going to explain to you the other options only, right? HBe antigen. Does it tell you patient is having acute infection? No, it only tells you patient is having high infectivity. You all know about it, right? Presence of HBe antigen is a marker of high infectivity only. And HBe antigen can be present in acute infection as well as chronic infection also, right? Don't forget that. Then detection of HBV DNA by PCR, that is also seen in both acute and chronic infection. So what I'm trying to say is HBe antigen positivity and HBV DNA detection can occur in both acute and chronic infection. Very important. Okay, chronic infection. Only thing is, if they are in high levels, it tells that the patient is having high infectivity. That's it, nothing else. Okay, right. Then tell me, what is the importance of anti-HBs antibody? Anti-HBs antibody. Anti-HBs antibody. It indicates seroconversion. It indicates seroconversion. What is the meaning of that? It indicates two things. Number one, patient could have had a previous hepatitis B infection which is now cleared from his body. That is why anti-HBs antibody is present. Number one possibility. What is the number two possibility? He could have been immunized against hepatitis B virus with a vaccine. That is why anti-HBs is positive, right? So basically, anti-HBs tells you the patient has got protection from hepatitis B infection, right? That is what, or he has recovered from the hepatitis B infection, right? That's it. Very, very simple point about hepatitis B, HBs antibody, okay, anti-HBs antibody. Are you able to follow this? Now quickly see what are the importance of these three antibodies in hepatitis B. I already told you anti-HBs AG tells you patient has undergone seroconversion. No doubt about it. We have just discussed that. Or patient has already recovered from the infection. Number one. Number two, anti-HBC. If IgM anti-HBC is positive, it means the patient has acute hepatitis B. Patient has having acute hepatitis B. And I'm sure in your microbiology classes, what have you learned? This is the only serological marker that is positive during which period? In window period. In window period, the only serological marker positive is IgM anti-HBC. That is also an important question. And if IgG anti-HBC is positive, what is the meaning? Patient is having a chronic hepatitis. Chronic hepatitis B. That is what? Patient is having chronic hepatitis B or sometimes remote infection also. But anyway, IgG generally tells you chronic hepatitis B infection. Then tell me, what does anti-HBe positivity indicate? Anti-HBe, see, think about this. HBe presence means what did I tell you? Patient is having high infectivity. Antibody against HBe is present. That is E antigen. You have an antibody. It means the patient is having low infectivity. Put it in the opposite way. That's it. Patient is having low infectivity. Are able to follow this, right? So this is the importance of the three antibodies in hepatitis B that you should know about. So anyway, the clear answer for our question, to prove acute hepatitis B infection, the investigation I have to do is nothing but IgM anti-HBC antibody. I hope this is clear. Everyone able to follow this? Okay, very good, right. Now let us move on to the next question. Question number 8. A 54-year-old patient with a known diabetes, okay, he's a known diabetes, he's having known diabetes, is presenting with liver cirrhosis. There is associated skin hyperpigmentation. An evaluation reveals restrictive cardiomyopathy. What is the initial test to diagnose this condition? Can you see there are so many findings given in this particular question? Number one, he's having diabetes. Number two, liver involvement, liver cirrhosis is present. Number three, hyperpigmentation is present. Number 4, cardiac involvement is present. So very clearly it tells you it's some sort of systemic disorder, multi-system disorder in that particular patient. We should know what is the name of the disorder and then only we can go on to what is the testing which we can do for this patient. Can anybody tell me what is the name of this disorder we are talking about? Name of the disorder. The name of the disorder in this condition is nothing but iron deposition in multiple areas of the body causing all this manifestation. That is a clue I'm giving you. Can anybody tell me the answer? Very good. It is hemochromatosis. It is hemochromatosis. Okay, basically a disorder characterized by iron deposition in different areas or organs of the body and causing all the features. Okay. Can you see? I'll come back to the question. I'll come back to the options. Can you see that? These are all the spectrum of manifestations which are due to hemochromatosis. Okay. Can you see that? What is that? Yes, major organs can get affected. Heart can get affected. Okay. It can lead on to cardiomyopathy. Liver involvement, hepatomegaly, and in end stage, it can lead on to even cirrhosis also. Then hyperpigmentation of the skin due to iron deposition. What do you call that? Bronze skin. Along with that, diabetes is also noted because pancreas tends to get affected. That is why this condition used to be called as bronze diabetes. Can you recollect the term? This condition used to be called as bronze diabetes. And lastly, it can also affect multiple organs in the body, multiple glands in the body. For example, the testis is affected. Testis affected can lead on to testicular atrophy also. And not to forget, arthritis involving the joints is also a feature of this condition. So you can see multiple type of manifestations due to iron deposition is what is the condition of hemochromatosis, right? Now let us recap some quick points about this hemochromatosis. Okay. In terms of investigation, that is what the question is asking about. Tell me, anybody, what is the initial test I will do to say that it is hemochromatosis or iron deposition? Something related to iron only. Can anybody tell me what is the test I can do? Elevated ferritin. Elevated ferritin I can do. Okay, ferritin levels will be elevated because iron is increased means ferritin levels are increased. Think about it. Iron deficiency anemia, ferritin level will be low, but here it is excess iron, so ferritin will be high. But that is one of the screening test or initial test I can do. I'll just write it is screening test which I will do. Anything else? Can anybody tell me to know for iron overload? Very good. Transferrin saturation. Transferrin saturation I can do. That test I can do. Transferrin saturation. I think all of you know how is transferrin saturation calculated. Transferrin saturation is calculated by any answer. It is serum iron divided by the total iron binding capacity or TIBC. What is going to happen in iron deficiency? You know it is decreased, but here it is going to be increased to more than 45%. More than 45%. Don't worry about the numbers. Just remember transferrin saturation is increased. Okay, but these tests can tell you, okay, some sort of iron is increased. But tell me which would be the accurate test to diagnose this condition? Most accurate test to diagnose this condition? Anybody? Most accurate test. If you are given this option, please choose this only. Liver biopsy. Liver biopsy is the most accurate test where we can estimate the amount of iron inside the liver itself. That is supposed to be the most accurate test for diagnosis of hemochromatosis, right? So that should be remembered very, very clearly. Anyway, going back to the question was asking about, what was the question asking? The question was asking, if it is hemochromatosis, what is the initial test to diagnose this condition? Initial means I told you something like a screening test only. So which is the screening test? Yes, of course, it is option A, that is transferrin saturation will be the one. See, of course, I do agree one more option is there, serum ferritin. But compared to serum ferritin, transferrin saturation is supposed to be the better test, and that is why I have gone with that as the answer. So anyway, the clear answer for this question is option A only, ferritin saturation. I do agree ferritin can be a possible answer, but I am not choosing it here because ferritin is one of the markers which can be increased during inflammation. So patient is having some sort of inflammation inside the body, falsely the ferritin level can increase. Are you able to understand? So you can get false positivity more often with ferritin. That is why I am choosing transferrin saturation as a better answer compared to serum ferritin. I hope you're able to follow this, everybody. Okay, fine. So this is something which should be kept in mind for this particular question of hemochromatosis. Let's move on to our next question. Next question. Yes. Question number 9. Read it. It's a picture-based question. We have a middle-aged male, presenting with heartburn, chest pain. Barium swallow was performed and shows the following finding. Which of the following treatment is likely to benefit in this particular patient? Okay. So this is a patient having chest pain and heartburn. That is okay. But our main clue lies in the barium swallow finding. Barium swallow is just to visualize the esophagus only, right? And you can tell me very quickly, what is this esophagus finding you're able to see? Okay, something like this coiled appearance. What is that? It's called cork screw appearance of the esophagus. Any idea which condition is this noted? Okay, this is noted in the condition of DES. What is that? Diffuse esophageal spasm. Okay, diffuse esophageal spasm. Okay, and now can anybody tell me the answer? What is it due to? Oh, sorry, what is going to be the treatment for this condition? Diffuse esophageal spasm. Okay, let us do a quick recap of the diffuse esophageal spasm and then we'll come to this particular question. Okay, right? See, basically the word spasm tells you it's some sort of contraction. Okay, it's some sort of contractions in that smooth muscle of the esophagus, right? But it is non-peristaltic contraction. It will not help in the movement of the food. That is what I'm trying to say. It is a non-peristaltic contraction. That non-peristaltic contraction is going to cause that corkscrew appearance of the esophagus. That is what we know about, right? Fine. Anyway, barium test can tell you about the corkscrew appearance of the esophagus. But tell me, which is the most accurate test to diagnose this condition? Most accurate test to diagnose this condition. Think about this. Whenever there is spasm happening in the esophagus, the pressure is going to be increased inside the esophagus. So for that, can you tell me the name of the test that can help in the diagnosis? Name of the test which will determine the pressure inside the esophagus. It is esophageal manometry. It is manometry. That would be the investigation of choice or the most accurate test in the diagnosis of this condition. Okay. Now you have to decrease the spasm in this patient. So tell me, what is the symptomatic relief or the drug I can give for this patient? Okay. Usually we give something like nitrates or calcium channel blockers for pain or spasm relief in this patient, right? So anyway, the clear answer for this question, it's a diffuse esophageal spasm. So the answer is going to be very, very clearly nitrates. Option B, it is nitrates. Okay. Now tell me, see, proton pump inhibitor is for GERD, which is not our diagnosis in this question. Esophageal resection, of course, is for conditions like tumors we can do. That is not the, diagnosis in this question. That is also ruled out. Tell me, Heller's myotomy, okay, right? Heller's myotomy is for which condition? This question, this option, sorry. Heller's myotomy is for which condition? Treatment. Achalasia cardia. You all know about it, right? It's a achalasia cardia. And can anybody tell me, achalasia cardia, what is the typical appearance you can get while doing barium swallow? Anybody? Achalasia cardia. Achalasia cardia, what is the typical appearance you can get? Anybody? Okay, I'll take up the picture. You can tell me the answer. This, sorry, 1 minute. Okay. Yeah, this is diffuse esophageal spasm, which we have already discussed. Corkscrew appearance of the esophagus. Yes, of course. This is the achalasia cardia, where you're able to see the lower end of the esophagus is narrowing or tapering. This is what we call it as bird beak appearance. Very good. This is called the bird beak appearance, noted in case of achalasia cardia, right? That should be remembered. Okay, right? Bird beak appearance. Okay, fine. So that's about this particular question. Anyway, just wanted to tell you because it's a related point and you should know about it. So anyway, the question we were discussing was diffuse esophageal spasm. For that, the treatment is going to be nitrates to decrease the spasm. That's it. So that was question number 9, which is now completed. We move on to question number 10. Yes, look at the question. Which of the following is not true? Yes, is not true about celiac disease. Okay, which of the following is not true about celiac disease? Okay, you all know celiac disease is a condition characterized by hypersensitivity to some food substance. What is that? Gluten present in the food. So that is why it's also called gluten hypersensitivity. It's a question where you have to analyze the options and tell me the answer straight away. Yes. HLA, DQ2, DQ8 predisposition. Is it true for celiac disease or not? Definitely it's a true association because patients with this HLA subtype have a high incidence of celiac disease. So that is correct only. Very good. IgA TTG antibody helps in initial evaluation. Is it true or false? Is it true or false? Yes, that is also true statement. TTG is nothing but tissue transglutaminase antibody. One of the antibody that is elevated in celiac disease and that can help in the initial evaluation, that is correct only. Small intestinal biopsy reveals villus atrophy and crypt hypoplasia. See, small intestinal biopsy is correct only. It reveals villus atrophy, but does it reveal crypt hypoplasia? No, it reveals crypt hyperplasia. Very important. It reveals crypt hyperplasia. You all know about it. That's one of the characteristic findings in celiac disease. So option C will be the answer for this particular question. Okay, right? Dermatitis herpetiformis may occur as extraintestinal manifestation. That is also correct only. I'm just going to put up some pictures related to the dermatitis herpetiformis also, right? So let us see quickly some important recap points about celiac disease for this question. We all know it's a condition of gluten hypersensitivity. It's a T cell mediated autoimmune damage to the small intestine. Very important. Okay, right? It's an autoantibody damaging the small intestine. And you all know that small intestine is a site of absorption. That is why when you see about the feature of this condition, malabsorption would be the feature of this condition. Malabsorption. That is why that patient will have a chronic diarrhea, weight loss, all these are due to malabsorption occurring due to small intestine damage, right? That is our basic understanding. Okay, fine. And it's a condition of gluten hypersensitivity also. And I think all of you should know about it. What are the food substances which are implicated? Barley, anything else? Rye and wheat. Barley, rye and wheat. These are the food substances which are implicated because they all contain gluten. Some of you were answering as oats also. I do agree, oats also is a possible gluten containing substance, but pure oats doesn't contain gluten. So that is why I'm not writing oats here. Processed oat does contain gluten and that can be implicated in the causation of celiac disease, but not pure oats, right? That is something which you need to keep a note of this. So very important for exams. Okay. Now tell me, what is the initial testing I'm going to do for these patients? I can look for the antibodies and the initial antibody I will do is anti-tissue transglutaminase antibody. That is the initial antibody testing I will do. And if there is a question, which is the most specific antibody in celiac disease? Anti-TTG is only for screening. Anti-TTG is only for screening. What about most specific? Most specific or diagnostic antibody. What is that? It is anti-EMA. What does EMA stand for? Endomysial antibody. Endomysial antibody. EMA. Okay, right? It is anti-endomysial antibody. That is for most specific. But if there is a question, which is the overall best test to diagnose celiac disease? Your answer is going to be duodenal biopsy. Overall best test is always for celiac disease. It is duodenal biopsy or the small intestinal biopsy. Never forget that important point. Okay, right? What are the findings you are able to see? Number one is this finding. What is this finding? All the villi are becoming very flat, or what you call it as villus atrophy. That is number one point. Villus atrophy. Number 2 point, what is that? The space between the villi is increased. Can you see that? The space between the villi is increased. What do you call that? It is called crypt hyperplasia. That is number 2 point. It is crypt hyperplasia. That is number 2. Number 3, if you magnify it further, in the villus epithelium, you can see increased amount of lymphocytes also noted. Okay, increased amount of lymphocytes also noted. Okay, right? So all these are characteristic findings related to duodenal biopsy, the small intestinal biopsy in case of celiac disease, which you should never forget. Okay, right. Now tell me, what is the name of this manifestation, which is something like papules or vesicles in the skin, papulovesicular lesion. These are like very itchy or pruritic lesion, papulovesicular lesions. Anybody? What is the name of this? Papulovesicular lesions seen in a patient with celiac disease. Very famous one called dermatitis herpetiformis. Okay, right? Dermatitis herpetiformis, one of the important extraintestinal manifestation of celiac disease also, right? This is a picture-based question, so you should be aware of this. Okay. Are you able to follow this, right? Okay. Anyway, so based on all the discussion, the clear answer for this question is option C only, because small intestine biopsy reveals villus atrophy, but not crypt hypoplasia, but it is crypt hyperplasia, right? That is what I want you to remember. Okay, right? So that was question number 10. which is now completed. Moving on to question number 11. Yes, have a look at the question. An adolescent girl on exposure to cold has pallor of the extremities followed by pain and cyanosis. She has similar episodes in the past. In later stages of life, she is most likely to develop which of the following problems? SLE, scleroderma, rheumatoid arthritis, dermatomyositis. First of all, you tell me, what is this called as? A girl, adolescent girl on exposure to cold initially develops pallor, followed by that pain and cyanosis. What do you call this presentation? It is called by a famous name called Raynaud's phenomenon. Correct? Very good. It is Raynaud's phenomenon. Very correct. Raynaud's phenomenon. Okay. Raynaud's phenomenon is what we remember as the set of changes that develops when when exposure to cold in some patients. Okay, not everybody, but in some patients we experience that. It is something remembered like this: PCR. What is that? P for pallor. P for pallor. Why? Due to vasoconstriction, the blood supply decreases. That is why pallor develops. P for pallor. After that, what happens is, when too much of blood flows decrease, there will be development of bluish discoloration. What do you call that? Cyanosis. Cyanosis. And also patient will experience pain at this time due to ischemia. Due to ischemia, they will develop pain also, right? That is for C cyanosis. And after that, what happens? Once the blood flow is re-established to the affected area, what will happen? It becomes very reddish. What is that? Erythema will be occurring, or a reddish appearance will be noted. Reddish appearance. That is what we remember in short form as PCR changes of Raynaud's phenomenon. Okay, PCR changes of Raynaud's phenomenon. Okay, fine. The question is asking, if the patient is having Raynaud's phenomenon, she is most likely to develop which of the following in later stages of the life? See, Raynaud's phenomenon, you should understand one thing, is associated with increased incidence of connective tissue disorders. And you can see so many connective tissue disorders given. In fact, everything is connective tissue disorder only. SLE, scleroderma, rheumatoid arthritis, dermatomyositis, right? But the question is most likely. That means which condition has highest association with Raynaud's phenomenon? It's a very fact-based question. Answer is option B. What is that? Scleroderma has got the highest association for Raynaud's phenomenon and should be the answer for this question, right? So this is purely based on your knowledge of high incidence of Raynaud phenomenon is noted in which condition? It is scleroderma. That's how the answer is derived for this particular question. I hope you're able to follow this. I'll just put up one line from the textbook also. Yes, I'll put up one line from the textbook. See here. Raynaud's phenomenon is associated with virtually every patient of scleroderma or systemic sclerosis. Okay, very important. Every patient, virtually every patient. That is what textbooks say. 95 to 99% of patients with Raynaud phenomenon, they go on to develop scleroderma or systemic sclerosis. Very, very important point that you should remember. This is not a pre-recorded version. It's a live session which is going on. Okay, right. Okay, right. So this is something which you need to remember. Then the second thing is, you can tell me, anyway, we are done with the question. So I'm just asking you some additional points. What is Crest syndrome and what is its association with scleroderma? Crest syndrome is nothing but an expansion for 5 features noted in the same patient. What is that? C for calcinosis cutis. C for calcinosis cutis. That means some calcium deposits noted in the skin. R is for the Raynaud's phenomenon, which we have just completed the discussion. What about this E for? E for esophageal dysmotility. E for esophageal dysmotility. Like patient will develop something like dysphagia. Okay, right? Dysphagia. Okay, dysphagia. Fine, dysphagia. What about this E for? Oh, sorry, S for. S is for the thickening of the skin. What is that? Sclerodactyly, causing tight fingers also. Due to thick skin in that area, patient will have tight fingers also. That is what we call sclerodactyly. Very good. Yes. And T is for dilated blood vessels or telangiectasia. Very good. For dilated blood vessels or telangiectasia. Just a minute. Okay. Yeah. The T is for the dilated blood vessels or the telangiectasia that you need to remember about. Telangiectasia. Okay. Now I have one question for you. That scleroderma or systemic sclerosis can have two varieties. One is called the diffuse type or the diffuse disease we can call it. Another one is called as a limited disease type of scleroderma. Okay, limited disease type of scleroderma. Tell me, Crest syndrome is noted in which type of scleroderma? I think one of you have already answered it. Very correct. It is only seen in limited disease type of scleroderma. Limited disease type of scleroderma. Okay, it is only noted in limited disease type of scleroderma. So please don't forget this. One more additional question. It's a fact-based question. You can try to tell me the answer. Yes. Antibodies in scleroderma. Tell me, limited disease or Crest syndrome. What is the name of the antibody? Okay, limited disease or Crest syndrome. What is the name of the antibody? Very, very correct. One of you have already answered it. It is anti-centromere antibody. A PYQ, please note it. Anti-centromere antibody. Whereas if the question is asking diffuse disease, what is the name of the antibody? It is anti-topoisomerase antibody. Very good. It is anti-topoisomerase antibody. Anti-topoisomerase antibody. That is yet another PYQ that you need to remember. In diffuse disease, it is anti-topoisomerase antibody. Yeah, that is what is SCL70. Some of you are talking about, right? Correct. That is what. Limited disease, it is anti-centromere. Diffuse disease, it is anti-topoisomerase antibody that you need to remember. Okay. So anyway, coming back to our original question, it was Raynaud's phenomenon. And the question was asking, Raynaud's phenomenon has got a highest association with which condition? It is scleroderma, right? That was the answer for our particular question. I hope you're able to follow this, everyone. Okay, very good. Now let us move on to our question number 12. Okay, question number 12. A middle-aged female is presenting with the complaints of low-grade fever for the last 6 months. Okay, for the last 6 weeks. Sorry, for the last 6 weeks. Recurrent cough as well as fatigue over the last 1 year. So it's a long-standing history in that particular patient. Examination reveals well demarcated 3 to 4 centimeter violaceous papules over the anterior aspect of her legs and face. This is a very important clue given in the question. Any of you can tell me what is that finding? Violaceous papules in the face, legs and the legs and anterior aspect of the legs and the face which is noted. Okay, let's keep that clue little later. One more important set of findings related to the chest X-ray feature. Anybody wants to comment on that chest X-ray? You are able to see lymph nodes in this region. Can you see that? Let me mark it. One enlarged lymph node here, one more enlarged lymph node here. This is hilar region and I will call it as bilateral hilar lymphadenopathy. Hilateral lymphadenopathy. Okay, both side lymph nodes are enlarged. Bilateral hilar lymphadenopathy, which is noted. Okay. Anybody? Okay, I will give you the clue also. You can try to tell me. This violaceous papules are not erythema nodosum. No, erythema nodosum are like nodules only, not as papules. Erythema nodosum is nodules, not papules. Violaceous papules is something what we call it as lupus pernio. Okay, now anybody wants to tell me what is the name of this condition? Bilateral hilar lymphadenopathy, lupus pernio, and long-standing respiratory involvement. Which condition? Very, very good. This is nothing but sarcoidosis. Nothing but sarcoidosis. Very, very important condition from an exam point of view called sarcoidosis. Maybe in your pathology classes also you learn about this, but it is important in medicine side also. That is why I am covering it here. Okay. See here, the question is, all of the following tests can be helpful in the evaluation of this patient's condition except, okay, in this patient condition except serum ACE, that is angiotensin converting enzyme levels, CD4 CD8 ratio in bronchoalveolar lavage, anti-DS antibody testing, and one more is serum calcium. Except is a question which is not helpful in the evaluation of this condition. Yes, any answer? Anybody? See, anyway, we have already arrived at the answer. It is sarcoidosis only. And please remember, this is the picture I want you to keep in mind. Okay, right? I'll just put it like an approach. We have already seen that, but still. Can you see that? This is the lupus pernio I was talking about, right? This is a lupus pernio. Along with that, patient is having hilar lymphadenopathy, right? Now, the sarcoidosis typically affects females in the age of 20 to 40 years, and that too black females. What I mean by black is something from the African community, right? That is what I'm talking about, right? African population, middle-aged females. This condition is a well-known problem. That is what I'm trying to say. Most of these patients can be asymptomatic also. Okay, so for example, when you do the chest x-ray and they have hilar lymphadenopathy, but you are not able to correlate with any other condition, then you may think about the possibility of sarcoidosis. That is what I'm trying to say. But if the patient is symptomatic, what is the most commonly affected organ? Of course, lungs are the most commonly affected organ, and that is why they develop all the cough, unexplained breathing difficulty. All these things are due to lung involvement only, right? Pulmonary sarcoidosis is the most common variety of sarcoidosis still. But sarcoidosis can have multiple manifestation, like what I have shown in this particular picture. And I am going to mark what are the important things that you should be aware of. Okay, number one, eye involvement, very very important, uveitis. Lung we have already seen, so leave that point, but eye uveitis is very important. Skin is yet another important one. What did I tell you? Violaceous skin plaques, that is lupus pernio. They can also have erythema nodosum also. Some of you were saying erythema nodosum, correct only, but the point to be noted is it was not given in the question, but it is one of the features of sarcoidosis that you should be aware of. And third important is the kidney involvement, hypercalciuria. Can anybody tell me why there is hypercalciuria? Anybody can tell me hypercalciuria? Basically, sarcoidosis is characterized by the presence of granulomas, which is nothing but collection of inflammatory cells, right? That is what chronic inflammation, you get granulomas. And the inflammatory cells in the sarcoid granuloma, they produce something called, what is that? They produce something called 1-alpha hydroxylase. 1-alpha hydroxylase. And where do you think 1-alpha hydroxylase comes into picture? It is in vitamin D generation. So what I'm trying to say is 1-alpha hydroxylase activity is increased in these patients, thereby resulting in increased vitamin D levels and finally resulting in increased calcium inside the body also. Increased calcium inside the body, and this increased calcium is also subsequently going to result in hypercalciuria as well. And as some of you were saying very correctly, the type of granuloma that occurs in this patient is non-caseating granuloma. Very correct. That's a pathology point. Non-caseating granuloma. Remember, in TB we study caseation or caseous necrosis or caseating granuloma, whereas sarcoidosis it is always non-caseating granuloma. Okay. So I was just trying to tell you some important findings related to sarcoidosis in terms of clinical features. Now, the question was asking about investigations in sarcoidosis. That is what I am going to discuss next. Anybody? All of the following can be helpful in evaluation of this patient's condition except anybody? Yes. Serum ACE, is it going to be helpful? Definitely it is going to be helpful because serum ACE levels are increased in the blood. Why? Because the cells in the granuloma, they produce AC, angiotensin converting enzyme, which enters into the blood, thereby the serum levels are increased and it's going to be helpful in this condition. What is BAL? Bronchoalveolar lavage. Is CD4 CD8 ratio going to be helpful? Definitely that is also going to be helpful, and the ratio is going to be increased. Why? Because in sarcoidosis, yes, in sarcoidosis there is a T helper 1 response, very important, T helper 1 response. T helper 1 response means which marker is increased? CD4 is increased or CD8 is increased? CD4 level is increased only. In fact, T helper 2 is for cytotoxic or CD8. That is not the main response. Here it is T helper 1 response. That is why CD4 levels are increased. So CD4 CD8 ratio testing is also very important in evaluation of sarcoidosis. That is correct. Anti-DS DNA antibody testing, not at all going to be helpful. Anti-DNS DNA antibody is going to be not helpful in this condition because it is only for condition like SLE, where we know that SLE, one of the specific antibodies is anti-DS DNA. Okay, right? So that is no way related to our question. That will be the answer also. Serum calcium, I told you it is going to be elevated. right? Why? Because of increased 1-alpha hydroxylase activity, there will be increased levels of vitamin D also, thereby resulting in increased calcium, hypercalcemia as well as hypercalciuria is also noted. So anyway, that is also going to be helpful. Okay, right? So the clear answer for our question is going to be option C only. There is no doubt about it. But if I ask you one more question, you can try to tell me the answer. Which is the overall best investigation to diagnose sarcoidosis? Anybody? Pulmonary sarcoidosis, which is the overall best investigation. First of all, you have to do bronchoscopy, and then you have to do biopsy also. And in the biopsy, what are you going to see? Very, very clear. It is this finding. What is that? You are going to see non-caseating granuloma. Very, very characteristic point. Non-caseating granuloma. That is supposed to be the hallmark feature in histopathology. When you do the biopsy in patients with sarcoidosis, that will be the final investigation that will clinch the diagnosis. I hope you're able to follow this, everybody. Okay, now one of you were saying in the comment section, KVM test. KVM test. It is actually an intradermal test. It is actually an intradermal test used to be done in patients with sarcoidosis. But now that test is not at all being done in clinical practice. It has become obsolete. It has become obsolete. So some of you are saying KVM test, right? KVM test is there, but nowadays nobody is using it. It's an obsolete test actually, right? That is why I did not mention it in the discussion purpose. Okay, I hope you're able to follow this, right? Anyway, so that was about our question number 12, which is completed. Moving on to the question number 13. Okay, yet another clinical scenario question. Have a look at the screen. A chronic alcoholic patient is presenting with sudden pain in the leg for the past few hours with the following finding. He has similar episodes in the past also. There is no history of preceding trauma. First of all, you should tell me with this presentation, okay, what should be the diagnosis? Okay, wait. One of you have asked the question, can we do MRI or PET? See, in sarcoidosis, let me write it in the previous thing. In sarcoidosis, MRI or PET can be done. I don't deny that. But more useful is a gallium scan. Okay, it's a gallium scan of the chest. That is going to be more helpful. But anyway, for your exam purpose, I don't think you need to know that. For your exam purpose, remember, biopsy is always the best investigation, right? That should be enough. Anyway, coming to the next question. What is this? What is this? It is nothing but this area, which is first MTP, joint inflammation, arthritis. What is MTP? Metatarsophalangeal joint arthritis. That is what you are able to see as redness, swelling and pain in that area. What is that? Yes, it's a very classical presentation of gout, or it's an acute gout attack. Can you see that? This patient is having an acute gout attack. That is why he is having the characteristic finding of that. And also remember, alcohol intake is one of the precipitating factors for attacks of gout also, right? So anyway, I don't think anybody has doubt in the diagnosis that it is an acute gout attack. Okay, fine. Right. Now, let us see this one. The question is asking which of the following is not true regarding this patient's condition, which is not true regarding this patient's condition. That is what is the question. Is it joint aspirate likely to show negatively birefringent crystals? Allopurinol should be started immediately. Colchicine is known to provide pain relief in this particular condition. Serum uric acid level may be normal at this time. Which one do you think is not true regarding this patient's condition? Yes, anybody? Analyze the option and put your answer in the comment section. Anybody? Okay. Okay, very good, very good, very good. I can see some correct answers and some different answers also. So I will come to the question. Let me just quickly take you through what happens in acute gout attack, right? See, gout is due to accumulation of what crystals? MSU crystals. What is that? Monosodium urate crystals, right? It is monosodium urate crystals which are accumulating in a joint and causing monoarticular arthritis, and the most commonly affected joint is the first metatarsophalangeal joint. All of you know about it, right? It is first metatarsophalangeal joint. That is what is given in the question also. What are the risk factors for this to occur? What are the risk factors for this to occur? One of the risk factors we saw in the question was alcohol intake, or what we call binge drinking, drinking too much of alcohol, binge drinking, more common in male gender, more common in males only. That is why mostly you get a question of male. And obesity is also an important risk factor for gout attacks. Okay, right? So these are all some of the important risk factors for this condition, right? And diagnosis is always you take the fluid from the joint area, or synovial fluid aspiration is supposed to be the diagnostic investigation in this particular condition. Okay, right? Diagnostic investigation. And tell me, what is the finding you are going to see? Wait, what is the finding you are going to see in this patient? If you do synovial fluid aspiration in a patient with gout, what is that you are going to see? You are going to see not this picture. This picture should actually come next actually. What you will be seeing in gout is this finding. Can you see that? What is that you are able to see? It's a needle shaped, negatively birefringent crystals. Negatively birefringent crystals. That is what you need to see. Okay, right? Negatively birefringent needle shaped crystals tells you it is gout only, or uric acid crystals are present in that particular condition. Now, can anybody tell me the next one? What is the second one? Anybody? Second one on the right side. It's a rhomboid crystal. It is not negatively birefringent, but I can say it is weakly, yes, it is weakly positive birefringent crystals. Anybody? What is this? That is pseudo gout. Very important. That is pseudo gout. Very good. That is pseudo gout. That pseudo gout is due to calcium pyrophosphate deposition. Calcium pyrophosphate deposition. Okay, it's an entirely different condition. But anyway, leave it as of now. What I was trying to say is, only by synovial fluid aspiration you will be able to diagnose this particular condition. That is what. Okay, right? Just trying to tell you differences between gout and pseudo gout in terms of pictures. Okay, let us focus our finding on the gout only. Tell me, are there any other investigations that can also be helpful? Of course, you know it is uric acid accumulation, means what would be the uric acid level? Generally, what are you expecting the uric acid level to be increased, or hyperuricemia only? But very important is, in acute attacks of gout, the serum uric acid level tends to remain normal or even decreased also. During acute attacks of gout, serum uric acid level tend to remain normal or decreased also. Can anybody tell me why? Can anybody tell me why? Serum uric acid should be increased only. Hyperuricemia only is gout. Then why I am saying uric acid levels are normal? Very important. During the time of arthritis or acute attack of gout, the uric acid from the blood migrates towards the joint area and gets deposited there. So all the uric acid in the body is going to be migrating towards the joint area. So if you take the blood sample, the levels will tend to remain normal or even decrease. This is what I want you to remember. Okay, right? So don't always expect high uric acid during acute attacks of gout. That is the point I want you to remember. Then X-ray may not tell you many findings during an acute attack, but if the patient is having recurrent attacks, okay, right, this is the type of X-ray which you may get. It is not for only one episode. Patient had recurrent attacks of gout, then you may see. Can anybody tell me what is that? You are able to see. Look at the, or follow the arrows. You can see some erosions like this. Can you see that? Small erosions in the bone can be noted. Any characteristic name for this erosion? Any characteristic name for this erosion? It is called rat bite erosions. Rat bite erosions. Okay, Martel sign. Okay, it's called rat bite erosions, right? That is what you need to remember. Okay, it is something called as a rat bite erosions. Okay, fine. Okay, these are the other additional investigation which we may do. Okay, right, in a patient with acute attacks of gout. Okay, fine, right. Now tell me the main discussion point: treatment of acute attacks of gout. Tell me, what is the first drug or the first line drug you will give for that patient? Remember, patient is in pain to the patient is in pain. To control the pain, what are you going to give? What is the first drug you are going to give? It is always high dose NSAIDs. No doubt about it. It is always high dose NSAID, like indomethacin, ibuprofen, like that only should be given. That is always the drug which we prefer during an acute attack of gout. One more drug which we may try is colchicine. Colchicine. Okay. Colchicine. Sorry. Yes, I think all of you have heard about colchicine. It's something like a tubulin migration inhibitor where it will prevent the migration of the inflammatory cells into the joint area, thereby decreasing the intensity of pain in that patient. Colchicine can also be used, right? That is something which you need to remember. So, high dose NSAID and aspirin. Now, tell me about the role of allopurinol. About the role of allopurinol. You all know allopurinol is a xanthine oxidase inhibitor which can decrease the levels of uric acid and can be helpful in the management of gout. But tell me, during acute gout, is allopurinol indicated or not? Allopurinol is not indicated. Very important point. Allopurinol should not be started in an acute gout because what can happen is it can actually precipitate another attack of acute gout also. It precipitates an acute attack of gout or worsens the problem in this particular situation. Okay, precipitates an attack of gout also. So that is why you will avoid allopurinol in patients who are having active arthritis or acute gout attack, right? That is what you need to remember. Okay, right? Yes. Chronic patients, of course, chronic gout patients, you have to start allopurinol, no doubt about it. But in an acute episode, always avoid allopurinol. It's a golden point or an important point that you should always stick to your mind, right? So if you go back to the question, okay, right? The question was asking, which is not true regarding this patient's condition. Joint aspirate is likely to reveal negatively birefringent crystal. That is correct, right? That is no doubt about it. It's a correct statement. Then, allopurinol should be started immediately. What did I tell you? You should wait. Don't start allopurinol now. It can worsen the condition. That's what I told you. Colchicine is known to provide pain relief in the situation. That's a correct statement. Serum uric acid level may be normal at this time. That is also correct. No doubt about it. So anyway, the clear answer for this particular question is going to be option D only. Allopurinol should not be started immediately during the acute attack of gout, right? I hope you're able to follow this. Fine. So that was question number 13, which is now completed. Moving on to our next question, number 14. A young female is presenting with a secondary amenorrhea and galactorrhea. Okay. Pregnancy test is negative. MRI brain shows a tumor of 5 millimeter diameter in the pituitary fossa. Basically, it's a pituitary tumor. That is what I'm trying to say. It's a pituitary tumor. Pituitary tumor. 5 millimeter. What does it tell you? 5 millimeter. Less than 10 millimeter, we call it as microadenoma. Microadenoma. Fine. Okay. No, during acute gout, nobody will use allopurinol, doctor, right? You can share the reference, but yeah, all the standard clinical guidelines say don't use allopurinol during an acute attack of gout, right? Fine. Anyway, so we have a pituitary tumor, microadenoma, which is causing the problems of amenorrhea and galactorrhea. Can anybody tell me what is your diagnosis first of all, which is causing pituitary, characterized with pituitary tumor along with that amenorrhea and galactorrhea, right? These are manifestations of increased prolactin. Increased prolactin. Or in other words, the diagnosis I am dealing with in this condition is prolactinoma. Okay, it is prolactinoma. Prolact, prolactinoma. Remember, prolactinoma is the most common functioning tumor of the pituitary. All of you should know about this. Can you tell me why increased prolactin level should result in amenorrhea and galactorrhea? Galactorrhea is very straightforward. Prolactin for milk production, thereby causing galactorrhea. That's a very easy explanation because prolactin is needed for milk production. That is why galactorrhea is a feature. Tell me why there should be amenorrhea related to increased prolactin. Okay, increased prolactin. Okay, maybe I'll just take the explanation like this. Increased prolactin inhibits the secretion of GnRH. Very important. It inhibits the GnRH secretion. Gonadotropin release hormone secretion. Because of inhibiting GnRH, what will happen to the LH and FSH? That level also will decreased. And because of that only, it manifests as amenorrhea, infertility and all the problems which are able to see in this particular patient, right? It is basically increased prolactin inhibiting GnRH, right? That is what I'm trying to say. Anyway, our clear answer or clear diagnosis for this question is prolactinoma only. Very good. Tell me, the question is about management. Okay, tell me, what is the initial treatment you will give for these patients? Okay, initial treatment you will give for these patients. Yes, it is nothing but dopamine agonist. Okay, it is nothing but dopamine agonist. I think all of you know this point. Dopamine will inhibit the release of prolactin or prolactin release from the pituitary. That is why dopamine agonists are useful in the management of this condition. What are the examples of dopamine agonists? The usual ones, bromocriptine and cabergoline. Okay, bromocriptine and cabergoline. Okay, bromocriptine and cabergoline, right? This would be the first treatment, initial treatment we'll give for every patient with prolactinoma. Suppose with only medical treatment it is not responding, then we go for the other treatment. What is that other treatment? We'll go for surgical resection. We'll go for surgical resection. We'll go for surgical resection. What is that? Transsphenoidal surgery. It is called transsphenoidal surgery. Transsphenoidal surgery. But that is not the first line treatment. First line is always dopamine agonist only. If that is not working out, then we may go for surgical resection. Now, if you go back to the question was asking what should be the management if the patient is having prolactinoma? Always choose bromocriptine as the answer. Surgical excision only if there is no response to bromocriptine. Radiotherapy has a very limited role, maybe like a last resort we can try. It is not the initial treatment and all. Methyl dopa is no way connected to this as an initial treatment, so that is also out. So anyway, the clear answer is dopamine agonist only. Bromocriptine should be the initial management for this patient with prolactinoma. So that was about our question number 14, which is now completed. Moving on to question number 15. Yes. A 55-year-old male, actually this is male patient, 55-year-old male patient who is a chronic smoker, okay, who is a chronic smoker, is presenting to the emergency with polyuria, polydipsia, nausea, as well as altered mentation for the last 2 days. He was recently diagnosed to have squamous cell carcinoma of the lung prior to this findings. What is the likely ECG finding expected in this particular patient? Okay, one of you have asked the question, if the size was more than 5 millimeter, can we go for surgical excision? Or you are trying to ask me the question that if it is a macroadenoma, should surgical excision be the option? No, in macroadenoma also, the first treatment is only dopamine agonist, doctor, because once you give the dopamine agonist, it will decrease the size of the tumor. Okay, decrease the features considerably, right? So surgery may not even be required. That is what I am trying to say, right? So what I am trying to say is, whatever be the size of the tumor in prolactinoma, the first treatment is always dopamine agonist only. Coming to the one more question which you had asked, both bromocriptine and cabergoline is given. Usually they don't frame questions like that because both are dopamine agonist only. But anyway, bromocriptine is the one which is very commonly used. So we can go ahead with that as the answer. Okay, fine. Okay, right. Now, this question, you can see patient is having complaints of polyuria, polydipsia, nausea and altered mentation for the last 2 weeks. He was recently diagnosed as squamous cell carcinoma. Okay, I'll come to that little later. But tell me, this polyuria, polydipsia, nausea, leave it, but altered mentation. With this complaints, can anybody tell me some electrolyte abnormality that comes to your mind? Electrolyte abnormality that comes to your mind. That is the clue I want you to say. Electrolyte abnormality that comes to your mind. Yes, it is hypercalcemia. It is hypercalcemia. Okay, it is hypercalcemia. Yes, basically what happens is increased calcium interferes with the tubule's concentrating ability. Okay, so it prevents the tubule from doing concentration of the urine. And because the concentrating ability is gone, what happened? There will be too much of water loss causing polyuria. Patient compensate by drinking too much of water. That is what is called polydipsia. That is what. Okay. Now, altered mentation is nothing but another feature of hypercalcemia only, which I am coming to little shortly. But tell me one thing, if it is hypercalcemia, which is the condition we are dealing with, what is the likely ECG finding in this patient? Now it becomes like a very straightforward question. Very good. It is narrowing of QT interval. Remember, hypocalcemia, prolongation of QT interval. Hypercalcemia will be narrowing of QT interval. So option D is the answer for this question. Okay, right? Now let me add some quick points which you should definitely know for the exam purpose. Hypercalcemia, whenever we talk about the manifestation, we always famously remember like this. What is that? Bones, stones, moans, groans, and an abnormal ECG. That is what we study, right? Bones basically refers to the bone pain. It is nothing but the bone pain. Due to bone resorption and weakness of the bone, the patient will experience bone pain. Stones refers to the kidney stones. That is what I am talking about. The renal stones or the kidney stones we are talking about. That is nephrolithiasis, again a part of hypercalcemia only. It can also be associated with polyuria and polydipsia. Moans refers to the neurological manifestation, CNS manifestation, in the form of depression, psychosis, all those things we are talking about. Groans is nothing but the abdominal pain. It is nothing but the abdominal pain noted in this patient with hypercalcemia. And ECG finding is our question which we have already discussed, which is nothing but shortening of QT interval. This is what we famously remember as the bones, stones, moans and abdominal groans along with abnormal ECG findings of hypercalcemia. Now let me ask you one more question related to this question only. What is the link? It was given, it was a chronic smoker with squamous cell carcinoma and the patient had hypercalcemia manifestation also. Correct? Can anybody tell me what is the link between squamous cell carcinoma and hypercalcemia? Anybody? What is the link between hypercalcemia and squamous cell carcinoma? Well, it is one of the paraneoplastic syndromes of lung carcinoma. It is one of the paraneoplastic syndromes of the lung carcinoma because what happens is squamous cell carcinoma is associated with production of something called PTH, parathyroid hormone related peptide. We call it parathyroid hormone related peptide. And we all know that parathyroid hormone is something which controls the level of calcium. So more production of parathyroid hormone related peptide will result in more calcium, that is why resulting in hypercalcemia. So what I am trying to say is it's a paraneoplastic manifestation related to PTH related peptide production. Similarly, you are going to tell me one more also. This we have already seen, PTH related peptide hypercalcemia. That is related to which carcinoma? Squamous cell carcinoma of the lung. There is one more type of carcinoma of the lung which can also have paraneoplastic manifestation in the form of small cell carcinoma of the lung. Anybody wants to comment? Small cell carcinoma of the lung, what are the paraneoplastic syndromes which comes to your mind? Number one, it can result in ACTH production, resulting in hypokalemia, Number two, it can result in ADH production, antidiuretic hormone production. Something like SAADH can occur. Something like syndrome of inappropriate antidiuretic hormone secretion can happen. Now tell me, what is electrolyte abnormality that it will cause? What is electrolyte abnormality that it will cause? It will cause hyponatremia. One of you are saying Pancoast tumor. Correct only. Pancoast tumor is not a paraneoplastic manifestation. Pancoast tumor is nothing but a bronchogenic carcinoma itself, but that affects the lung apex. Okay, apex of the lung, right? That is what is called Pancoast tumor. It is not a paraneoplastic manifestation. It's a tumor itself. That's it. Are you able to follow, right? So these are the points which I want you to remember related to small cell carcinoma of the lung as paraneoplastic syndromes. Anyway, coming back to our question, it was clear. Hypercalcemia and hypercalcemia on an ECG is typically characterized by shortened or narrowing of the QT interval. That's it. I hope you're able to follow this, right? So that was about our question number 15, which is completed. Moving on to question number 16. Yes, yet another long question, but an important question based on a recent PYQ. Yes, so look at the screen. A 25-year-old female has recurrent episodes of sweating and headache. Her mother had a history of renal calculi and died after having a neck swelling. Okay, right? Something like a family history. Okay, right? A family history is very significant or it's an inherited condition. Fine. What is that family history? Neck swelling along with that renal calculi, and the mother had died due to that also. Fine. The physical examination of the patient reveals a thyroid nodule. Okay, can you see that patient is having some thyroid nodule but no overt features of thyroid dysfunction? That means hypothyroidism features are not present in that patient. it was decided to remove the thyroid nodule in this patient, right? So the surgeon decides, okay, I have to remove the thyroid nodule to see what it is. Question is, before surgery, the surgeon should do which of the following on a priority basis? That means before you operate on this patient, which of the investigation you will do on a priority basis? That is what is the question. Is it measurement of T3, T4, TSH, or calcium phosphate alkaline phosphatase estimation, or 24-hour urine testing for 5-hydroxyindole acetic acid, that is what is 5-HIAA, 24-hour testing for catecholamine, metanephrine and VMA, what is that? Vanillyl mandelic acid excretion in the urine, which you will do in this patient before you operate for the thyroid nodule. First and foremost thing, based on all clues which are given in the question, let us try to formulate a diagnosis and then we'll come back to the option. Short approach. Patient has a thyroid nodule. Patient also has recurrent headache and sweating. That is what the question says. No symptoms of thyroid dysfunction, that means hypothyroidism is not clearly present, but there is a significant family history of mother having a renal calculi and died of neck swelling. I am saying the neck swelling could be probably something like a thyroid mass, right? Because this patient is also having thyroid nodule, right? So tell me, what are all the features you are able to see? Some sort of thyroid problem, some sort of renal calculi, and I am going to give you a correlation. We have just studied renal calculi could be due to hypercalcemia, and that could have been due to increased levels of PTH in the patient, or parathyroid problem is also noted in this particular patient. Sorry, parathyroid problem is also noted in this particular patient. Parathyroid problem is noted in this patient. Okay, so I have thyroid problem, parathyroid problem also, and third is this recurrent headache and sweating could be due to pheochromocytoma, which is causing increased amount of catecholamines in the blood, and that is causing headache, sweating, palpitation like that in this particular patient. Tell me, pheochromocytoma, parathyroid increase, possibility of a thyroid tumor or a mass like that, which condition or diagnosis comes to your mind? Anybody? It is one of the men syndromes, multiple endocrine neoplasia syndromes. It is very, very important for exam purpose. Okay, all of you have studied so many types, men 1, men 2, men 2A, all those things. Can anybody tell me what is this men syndrome? Which is characterized by, actually PTH is parathyroid hyperplasia. I am giving you clues. Parathyroid hyperplasias. Okay. Number 2 is pheochromocytoma, already given in the question in this slide I have just told you. Number 3, the thyroid mass is something like MCT. What is that? Medullary carcinoma of thyroid. Medullary carcinoma of thyroid. Anybody? With this 3 finding, which men condition comes to your mind? Well, it is men 2A. It is men 2A. Okay, right? That is what you need to remember, right? It is men 2A. Are able to follow that, right? It is men 2A, right? That is what is my diagnosis in this particular patient. Okay, right? Okay, anyway, because it's a tumor of the thyroid, I have to go for thyroid resection. But tell me, out of these 3 conditions, which is priority? Which is priority in this patient? Which is priority I have to treat in this patient? Priority is always pheochromocytoma. Priority is always pheochromocytoma, because what happens is, if you don't treat pheochromocytoma or control the levels of catecholamines and you just like that take up the patient for surgery, what is going to happen? There will be too much of output of catecholamines during the time of surgery, because it's a stress for the patient, and that can result in arrhythmias and even death also in that particular patient. Abnormally high BPs can happen and patient can die in the operating table itself, right? So I am saying my priority is to think about pheochromocytoma and treat pheochromocytoma before even I operate the patient. So tell me, which option will be the correct option? It is obviously the last option. What is that? It is testing for catecholamines, metanephrine and VMA excretion only. That will be my priority, to think about pheochromocytoma, control the pheochromocytoma, and then only take up the patient for surgery. If you see T3, T4 and TSH, it's not going to be helpful, because anyway patient is not having any thyroid dysfunction. You may think about medullary carcinoma of thyroid, but in medullary carcinoma of thyroid, the thyroid levels are usually normal only. Very important. For MCT, can anybody tell me testing of which is going to help? It is calcitonin. Calcitonin only will help because calcitonin levels will be elevated. But even then, that is not my priority. So I'm not going to do that testing also now. Number two, determination of calcium phosphate, alkaline phosphate. This is for what? Parathyroid elevation. You can get alteration in these levels. But again, that is not a priority. 5-hydroxy indolactic acid. What is it for? It is for evaluation of carcinoid syndrome. Carcinoid syndrome, which is no way related to the question which we are discussing. So that is also out. So anyway, the clear answer is I have to think about pheochromocytoma, test in that same line and then treat if it is noted, right? Before I take up the patient for surgery. So for this question, it's a very, very clear answer. That is option D only. Okay, right? That is what you need to remember. It's a little long question, but still very important from an exam point of view because in the recent exams, last 3 years, I have seen good number of questions from men syndrome. That's why I want you to make a clear note of it. Is it clear, everyone? Fine. Let's move on to our next question. Yes, question number 17. A 32-year-old female with a history of Graves' disease is brought to the emergency department by her husband. She is extremely agitated, confused, and appears to be markedly diaphoretic. Diaphoretic means sweating is noted. Her symptoms began abruptly 4 hours ago, shortly after she developed a high-grade fever and pruritic cough. Or in other words, after this patient had a something like an infection, like a trigger. Patient is having all these problems of um, agitation, confusion, diaphoresis and all, and she is already a patient having Graves' disease. And you can see the risk factors, physical examination, what are the findings you are able to see? Temperature is elevated, she is having fever, heart rate is increased definitely, tachycardia, along with the irregular rhythm, and blood pressure is also elevated. Can you see that 150 by 90? She has visible goiter and mild proptosis, all part of Graves' disease only. Tremors are also noted, okay, right, which could occur due to hyperthyroidism seen in Graves' disease. Now tell me, this is a patient already having Graves' disease, hyperthyroidism, but having an emergency scenario where she is presenting to the emergency room with all these findings with the trigger of infection. Do you know what is the name of this condition? Some of you are answering it very correctly. This is what we call it as an emergency scenario, that is thyroid storm. Okay, right? This is what we call it as a thyroid storm. The typical presentation is what I have given. Question is, all of the following are useful in the management of this patient's condition except propyl thiouracil, PTU, intravenous propranolol, aspirin, hydrocortisone. Except means which is not useful. Which is not useful. Anybody? Which is not useful in the management of this condition? Any answer? Anybody? Okay, see, very simple. Our aim is to control the thyroid hormone levels because that is what is causing the problem. And second is some of the features also you need to control. Yes, think about this. It is something like a stepwise management I am putting up in this picture, right? Quickly see. First and foremost thing, the first step is beta blockade, right? First step is beta blockade only because I have to control the heart rate. Did you see the heart rate was 172, right? Very, very high heart rate. I have to give beta blockers to control the heart rate, number one. Number two, to take care of the thyroid hormone, I will give anti-thyroid medication, and that too, PTU, propyl thiouracil is preferred compared to the carbimazole, right? What is the reason for that? Because it blocks T4 to T3 conversion also, not only inhibiting the production of hormone, it also blocks the conversion of T4 to T3. And you know T3 is the active form of the thyroid hormone. So that blockage is also very important for us. So that's why we are preferring propyl thiouracil here. Number 2. Number 3 is steroids, okay, glucocorticoid, because they control the inflammation, treat the adrenal insufficiency, and also have an additional role of reducing T4 to T3 conversion, okay, right? And finally, what we can do is you can give organic, inorganic iodide, which is a potassium iodide, which blocks the release of thyroid hormone with the help of an effect. Very important, you all know about it, called Wolff-Chaikoff effect. I am putting a star for that. Okay, right, blocks the release of thyroid hormone, thereby helping in the management of this condition as well, right? So this is like a stepwise management of thyroid storm which we need to follow. Beta blockers, propyl thiouracil, steroids, and then potassium iodide, right? That is what you need to remember in a sequence. So very clearly the answer for this question is aspirin has no role in the management of thyroid storm, and that will be the clear answer for this question. Is it clear? Thyroid storm is always a favorite question for the examiners, so you should make a special note of it, right? That is why. So that was question number 17, which is now completed. Moving on to question number 18. Yes. A 52-year-old male presents to the clinic with a complaining of progressive shortness of breath and persistent dry cough. He has worked for over 20 years in a facility specializing in sandblasting and granite cutting. A chest X-ray reveals multiple nodules, okay, multiple nodules in the upper lobe of the lungs, along with the eggshell calcification of the hilar lymph nodes. Pulmonary function testing, that is lung function testing, reveals a restrictive pattern. This patient is at increased risk of developing the following complications except. You can see the option TB, bronchogenic carcinoma, mesothelioma and COPD, right? Others have a look at this question. I'll see some of the queries which has been asked. Why propranolol more than metoprolol? I never mentioned like that. Propranolol is a usually used drug. That is what I had mentioned. I didn't say propranolol more than metoprolol, right? I didn't say that. What is the next one? What is the next one? Can you please explain PTH increase in pheochromocytoma? No. I didn't say PTH will increase in pheochromocytoma. No. PTH increase is one of the features noted in MEN2A syndrome, and in MEN2A syndrome, pheochromocytoma is also present. That is what I said. I never said PTH increases in pheochromocytoma, right? Both are different, but a part of MEN2A syndrome. That is why. Okay, fine. I am going to approach this question. It's a very straightforward question actually. What is that? This is a clue. What is that? It's a 52-year-old male, but for 20 years he has worked in this sand blasting and granite cutting industry. What is it? It's an occupational exposure where there is an exposure to silica in this industry, or in other words, it's a silicosis condition we are dealing with. The important clue given is occupational exposure. Silicosis is also characterized by the other two findings. What is that? Eggshell calcification and also nodules in the upper lobes, right? That is also notorious for silicosis only. That is also notorious for silicosis only. So the question is very simple now. In a patient having silicosis, there is an increased risk of all of the following complications except, like that is the question. Okay, right? Tuberculosis, definitely increased risk is there. Bronchogenic carcinoma, definitely increased risk is there. Remember, silica is a class 1 carcinogen itself, so it can result in bronchogenic carcinoma. Mesothelioma, is it associated? No. Mesothelioma is something like an association for the other pneumoconiosis. What is that? It is only for asbestosis it is associated. In fact, what you have studied, the most specific cancer associated with asbestosis is mesothelioma only, right? So it is an association for asbestosis, not for silicosis. COPD risk is also increased in patients with silicosis because any dust exposure increases the risk of COPD, so that is also correct only. So anyway, the clear answer for this question is mesothelioma only because that is not an association with silicosis. And please remember, silicosis, it's a one-liner, is the most common pneumoconiosis in India. Most common pneumoconiosis in India is silicosis. That also should be kept in mind. It's a one-liner question. Yes, so all these are points to be kept in mind, right? So that is about our question number 17, which is now completed. Just a minute. I think there is a small shift in the ordering of the questions. Okay, so that was question number 18. I'm sorry. Okay, right. That was question number 18, which is completed. Okay, fine. Yes. Now moving on to our question number 19. Okay, right. Question number 19. Okay, this is a very straightforward question also, but an important one where we have to differentiate between basically two conditions, right, based on the clinical features. A patient develops fracture shaft of the femur, okay, right, fracture shaft of the femur. On day 3, he develops respiratory distress and decreased SpO2, along with that petechiae also. What is the probable diagnosis? Is it hypostatic pneumonia, pulmonary embolism, crush syndrome, or fat embolism? It's a close call, but you should tell me the answer. Which one? Following a fracture of shaft of femur, what can happen is there will be release of fat globules. There will be release of fat globules. There will be release of fat globules into the blood or into the circulation. what can happen is these fat globules, once they release into the blood, they can block the blood vessels. They can block the blood vessels. Which areas they can block? They can block the blood vessels in the lungs. That is why this patient can develop respiratory distress as a feature. Okay, decrease SpO2 also. They can cause some blockage of blood vessels in the skin also. Thereby, they can develop petechiae also. One more area where there can be a blockage is in the brain or CNS. That is why they can develop features like confusion or mental abnormality. Something like that can also be there, which is not given in the question. But anyway, based on the features given in the question, what is the clear answer? The clear answer is nothing but fat embolism only. No doubt about it. It is fat embolism. And fat embolism typically occurs 24 to 72 hours after the fracture. After the fracture. Okay. After the fracture. Can you see in this question also? When is the patient developing all the problem? It is day 3, which is well within the range of 72 hours, right? Okay. Now, among the other options, okay, right? See, crush syndrome. Can it be the answer for the question? Crush syndrome. Crush syndrome cannot be the answer for the question. In crush syndrome, what is the main problem? Following a trauma, there is a muscle damage. There is a muscle damage due to which the patient will develop urine discoloration. What is the reason for urine discoloration? It is myoglobinuria. Myoglobinuria. And because of muscle damage, there will be elevated levels of creatinine kinase also, right? That is how the presentation will be. It will not be like respiratory distress, petechiae like that. So that is anyway out for this particular question. Look at the first option, hypostatic pneumonia. It is not a very common term, but still I'll just tell you what it is. Hypostatic pneumonia means patient, a bedridden patient. For example, a bedridden patient who is lying down on only one side, not able to turn around. That patient can be predisposed to develop pneumonia. But again, in pneumonia, will there be petechiae as a finding? Will there be a fracture shaft of femur and all given? No, it is no way connected to pneumonia, so that is automatically out. There can be some confusion related to pulmonary embolism because pulmonary embolism is also characterized by respiratory distress and low SpO2, low SpO2. And pulmonary embolism can also occur following a shaft of femur. Why? Because following a fracture shaft of femur, the patient is having immobilization, correct? The patient is having immobilization, which can predispose to pulmonary embolism. So now tell me, how will I differentiate? It is not pulmonary embolism in this particular question and it is only fat embolism. Anybody? Okay. The most important clue is the onset. The onset of clinical features in pulmonary embolism is more than 5 days of immobilization, not in the first 5 days of immobilization. Can you see that? In this question, it was clearly written day 3. Day 3 means what? 72 hours only. It is not first 5 days. After 5 days of immobilization only, features of respiratory distress will occur in pulmonary embolism, not within 5 days, right? That is one, number one. Number two, petechiae is never a finding of pulmonary embolism. So that also will help us to rule out pulmonary embolism in this particular question. Are you able to understand what I am talking about? Yes, yes, yes. That is what. One of the important clues whenever you see the question you will get is the timing. That is what I am trying to say, right? It is a timing which will help you to differentiate between the two conditions. So this is more of how to say, purely analytical question, but still important from an exam point of view. So fat embolism is a clear answer for this particular question. Okay, right. And some of you are answering yes, of course. In crush syndrome, you can also have features of renal failure also. That's an excellent point. Renal failure features also will be present. Myoglobinuria will be present. So that can help us to rule out, right? That's very correct. Okay, fine. Now moving on to our question number 20. Yes. Question number 20. A 65-year-old, a 65-year-old thin-built male who is a chronic smoker is presenting with shortness of breath and cough for many years duration. Chest X-ray reveals hyperinflated lung fields with tubular appearance of the heart. Lung function testing reveals low FEV1, which shows no improvement after a bronchodilator. All of the following are useful in the management of this patient's condition, except. That is what is the question. Anybody wants to answer? See this. It's a elderly smoker who is having cough and shortness of breath for many duration, right? It's something like a respiratory problem only, no doubt about it. And to give you clues only, the next 2 points are very important. Chest X-ray reveals hyperinflated lung fields and tubular appearance of the heart. And to give you one more clue, lung function testing reveals low FEV1. Low FEV1 is noted in obstructive lung diseases, right? We all know about it, but shows no improvement after a bronchodilator. That means what? It's a irreversible obstruction. That is what? Irreversible obstruction. Tell me which condition comes to your mind. It is COPD only. It is COPD. Because if there is an improvement following a bronchodilator, you will think about which condition? Asthma. But here it is clearly mentioned there is no improvement following a bronchodilator. That means it's an irreversible obstructive lung disease, which is nothing but COPD. And tell me in which COPD? COPD we have two things. What is that? One is chronic bronchitis, another one is emphysema. Which type of COPD is characterized by hyperinflation in the lung fields along with tubular appearance of the heart? Tubular means like a thin appearance of the heart, right? The thin appearance is basically due to hyperinflation. Which of the condition? Very correct. It is emphysema. It is emphysema, which is very important condition, COPD, characterized by this hyperinflated lung fields, right? That is what you need to remember. So anyway, all of the following are useful in management of this patient condition except long-term oxygen therapy, one of the important things, because these patients have hypoxia. Long-term oxygen therapy is very helpful in the management. Smoking cessation is a must, because once the patient quits smoking only, there will be prevention of progression of COPD. So that's why it is important. Omalizumab. What is omalizumab? It is anti-IgE antibody, which is helpful in which condition? It is only for asthma, not for COPD. So that is why omalizumab will be the answer for this particular question. It's a very straightforward one. Inhaled corticosteroids, we don't use them initially in COPD, but if the patient is having persistent problems in spite of using oxygen, smoking cessation, then we may use inhaled steroids also. But omalizumab is never useful in COPD, so that is why it is a clear answer for this question. So anyway, just have a look at this. This is like a basic representation of COPD management, where we initially go for smoking cessation and LTOT. What is LTOT? It is nothing but long-term oxygen therapy. Then the second step would be giving bronchodilators like short-acting beta agonists and long-acting beta agonists. And third, patient is having refractory symptoms, okay, right, or refractory features. In spite of using all the drugs, refractory features, then we may go for inhaled corticosteroid also as a last step, right? This is like just a quick outline of management of COPD only. So anyway, the clear answer for this question is going to be option C only. Omalizumab is not going to be helpful in the management of this particular condition. That's it. Are you able to follow? Fine. Right. Now, the next question is question number 21. See here. An adult male who is having chronic kidney disease is noted to have renal osteodystrophy with elevated PTH level. Okay, right? With elevated PTH level. The initial treatment for management of this condition is, you all know that CKD or chronic kidney disease can result in renal osteodystrophy. What is the meaning of that? Bone problem related to kidney disease. Can you tell me why? Why renal osteodystrophy in CKD patients? Before we go to the answer, why renal osteodystrophy in CKD patient? Number one point, remember, kidney has an important enzyme which is related to vitamin D metabolism. What is that? 1 alpha hydroxylase. 1 alpha hydroxylase. What happens in CKD patients? In CKD patients, the 1 alpha hydroxylase level will be decreased. Because of that, what is the problem? There will be decreased production of 125 dihydroxy vitamin D, or the active form of vitamin D production itself is decreased. Because of which, what is going to happen? There will be low calcium, and to counteract the low calcium, what will be the response? There will be increased PTH, or in other words, secondary hyperparathyroidism will develop. Okay, and you know that that will cause bone erosions, and then problems in the bone will happen, right? That is why secondary hyperparathyroidism will happen related to low calcium and increased PTH. Any other important problem? They can also have hyperphosphatemia. What is the reason for hyperphosphatemia? In chronic kidney disease, the kidney cannot excrete the phosphate. The kidney cannot excrete the phosphate because of poor functioning. That is why it leads on to hyperphosphatemia also. So two things you need to remember: low levels of vitamin D causing secondary hyperparathyroidism, and one more is hyperphosphatemia. These are the reasons why bone tends to get affected in case of this particular condition, right? So now, how are you going to manage patients with CKD as well as having bone problem? Number one step is to manage what? Is to manage hyperphosphatemia. How are you going to manage hyperphosphatemia? Number one, you have to restrict any sort of phosphate in the diet, like dairy products have to be decreased. Any other thing you can tell me for managing hyperphosphatemia? Anybody? Managing hyperphosphatemia. Very good. Phosphate binders. Okay, phosphate binders should be given. Very important. Phosphate binders should be given. Tell me some examples of phosphate binders. We all know about it. Calcium based binder. What is that? Calcium acetate, calcium citrate, like that. I'll write one example. Calcium acetate, sorry, calcium carbonate or calcium acetate. That is one calcium based binder. Any of you know some non-calcium based binder? Non-calcium based binder. Very good. Sevelamer. Sevelamer. It's a non-calcium based binder that is also helpful in the management of this condition, right? So number one step is to control phosphate. Number two, what is the second step I have written? Address the secondary hyperparathyroidism. Okay, secondary hyperparathyroidism. What is the reason for secondary hyperparathyroidism? I told you. Yes, it is vitamin D deficiency because the kidney cannot produce the vitamin D. So you have to give vitamin D, and that too, active form of vitamin D should be given for this patient. So vitamin D should be given as a next thing. Okay, right? So anyway, going back to this question, with all this discussion, if I go back to this question, the question is saying what should be the initial treatment for patients having renal osteodystrophy and elevated PTH level? What should you do? Very correct. I will first tackle, what is the step one I told you? Phosphate binders to control the hyperphosphatemia. Okay, that is what I am trying to say. So the clear answer for this question is option D only. I hope you are able to follow this. Everyone able to follow this, right? So this is basically a question asking you about management of bone problems related to chronic kidney disease. I hope you can follow that, right? So that is about our question number 21. Now we move on to our next set of questions, all related to the cardiology part and obviously very important for your exam purpose. Yes, let us see the questions one after another. Okay, case scenario question. Yes, a 64-year-old male with a history of poorly controlled hypertension presents to the clinic complaining of progressive exertional dyspnea and fatigue over the last 6 months. On physical examination, blood pressure is high. Can you see that? 150 by 90. And heart rate is 82 also. Auscultation reveals a soft S1 and a high-pitched blowing holosystolic murmur. Holosystolic means nothing but pansystolic murmur, which is radiating towards the apex or loudest at the apex. Loudest at the apex. The murmur radiates significantly towards the left axilla and does not change in intensity during inspiration. The question is, with all these features, what is a likely diagnosis? Is it aortic stenosis, ventricular septal defect, mitral regurgitation, tricuspid regurgitation? Okay, I'll go back to the question. See, exertional dyspnea, fatigue may not give you any clues to the diagnosis. But what is going to give you the important clue to the diagnosis is these 2 points. What is that? Soft first heart sound, that is S1. And second is the pan-systolic murmur, which was heard maximum at the apex. With this itself, you can tell me the answer also. What is that? Which condition? Which condition causes this pansystolic murmur loudest at the apex? Very, very good. It is mitral regurgitation. Mitral regurgitation. Okay, right? See, how are you going to rule out the other option, right? Quickly tell me. First of all, aortic stenosis. Aortic stenosis straight away ruled out because what type of murmur is caused in aortic stenosis? It is ejection systolic murmur. It is ejection systolic murmur, not pansystolic murmur. So that is straight away ruled out. But all the other three conditions, all these three conditions can cause a pansystolic murmur. All these three conditions will cause pansystolic murmur. VSD will cause a pansystolic murmur. Mitral regurgitation cause pansystolic murmur. Tricuspid regurgitation also cause pansystolic murmur. Then how will you differentiate? That is what is my next question. Yes, in VSD, very, very important, the murmur is not heard at the apex loudest. Where it is heard? It is heard at the lower left sternal border. Very important. It is heard at the lower left sternal border. Very important. Not at the apex. Right? And will it radiate towards the axilla? No, it will not radiate. This murmur will not radiate. Whereas in the question it was clearly written, the murmur is radiating towards the axilla. That is only possible for mitral regurgitation. It is not possible for ventricular septal defect. That is what. Now tell me, tricuspid regurgitation. How are you able to rule that out? Anybody? Tricuspid regurgitation, that is also causing pansystolic murmur only. Again, tricuspid regurgitation also, the murmur is loudest in the lower left sternal border. Lower left sternal border. That is what some of you are saying as parasternal border. I accept. And one more important point for tricuspid regurgitation is the murmur increases. Very important. The murmur increases in intensity with inspiration. In tricuspid regurgitation, the murmur increases in intensity with inspiration, and this is given a sign also. Any of you know what is the name of this sign? Yes? Any of you know what is the name of the sign? It's called Carvalho's sign. Carvalho's sign. The murmur increases in intensity with inspiration. But can you see, if I go back to the question, it was clearly written that for this particular question, murmur does not change in intensity during inspiration. Why? It is not tricuspid regurgitation. It is a mitral regurgitation. That is what I am trying to say. So anyway, I was just trying to tell you 3 options can have pansystolic murmur, but we choose mitral regurgitation for 2 reasons. Number 1, it is loudest here at the apex, and number 2, it is radiating towards the axilla. The other things are parasternal or lower left sternal border only, and tricuspid regurgitation increases in intensity also, right? So anyway, so this is something which is very clear. So the answer for this question number 22 is going to be mitral regurgitation. It is done. Okay. Moving on to question number 23. Important topic. Please listen to it carefully. Anybody? A 68-year-old man presents to the outpatient department with the complaints of palpitation and fatigue for the last 2 days. He has a history of hypertension, but is otherwise stable. That means blood pressure, everything is okay, right? He's hemodynamically stable. That is what I'm trying to say. It's a very important clue for us in decision making. That's why just marking it. He's hemodynamically stable. ECG reveals the following finding. What should be? Okay, I'm not asking the question now. Tell me ECG finding. Very important in a patient with palpitation. This is the finding. I'm just putting it in a bigger view also. Yes. Anybody wants to comment? First of all, you tell me 3 things you have to tell me. Is it a regular rhythm or irregular rhythm? How do you decide? Look at the RR interval. Is the RR interval same or different every time? No, it is very different. That means it's a irregular rhythm. That is what is my number 1 clue. Irregular rhythm. Okay, fine. Then look at the QRS complex. It is only 2 boxes, 2 small boxes. Normal QRS complex is like 3 small boxes, or in other words, I am trying to say it's a narrow QRS complex. Narrow QRS complex. Only 2 boxes of QRS is noted. Third is look at the P wave. Are you able to see a clear P wave? Are you able to see a clear P wave before the QRS complex? No, I am not able to see a clear P wave. Instead, the wave looks like this only. What is this type of wave called? This type of wave is what we call F wave or fibrillatory wave. Fibrillatory wave, not a P wave. So tell me, based on these 3 features, irregular rhythm, narrow QRS and presence of fibrillatory wave, the clear diagnosis is going to be AF. What is AF? Atrial fibrillation is a condition we are dealing with. Atrial fibrillation is a condition we are dealing with. This ECG is extremely important for exams. Okay, right? Irregular rhythm, narrow QRS and fibrillatory waves. Okay, one of you had mentioned it is atrial flutter. Please don't forget this. Atrial flutter will not have fibrillatory wave. What type of waves you will get in atrial flutter? You will get this type of waves in P. What is that? It is something called as sawtooth waves. Sawtooth waves. That is for atrial flutter. But for atrial fibrillation, it is fibrillatory waves or the F waves. That is what you need to remember. Okay, fine. Okay, anyway, for our question, the diagnosis is atrial fibrillation. And the question asks, what is the most appropriate initial management for rate control in this patient? Okay, right? Rate control in this patient. Is it intravenous amiodarone, electrical cardioversion, beta blockers, or catheter ablation? Question is about controlling the rate, that is a heart rate I am talking about in this particular patient. Very clear. Control the heart rate, what should you do? Yes, it is nothing but beta blockers only. It is nothing but beta blockers. Beta blockers only will control the heart rate for rate control in this patient, right? Anyway, I'll just add some quick points about this atrial fibrillation, which is important from an exam point of view. Remember, atrial fibrillation, the heart rate is very high because of multiple ectopic foci, which starts from the left atrium of the heart. Left atrium, there are multiple ectopic foci which produces multiple impulses and thereby causing this problem. And because there are multiple ectopic foci, what can happen? There is an increased risk of thrombosis also. There is an increased risk of thrombosis also. That is why all these patients can be having increased risk of thromboembolic complication. For example, stroke can also develop in this patient. That is why in the management aspect of this patient, which is definitely important to decrease the risk, of thromboembolic complication, what is the drug you will add in the management of this patient? Very, very important. Anticoagulants should be added in the management of all patients with atrial fibrillation. Don't forget this. Anticoagulant should always be added in all patients with atrial fibrillation. Please don't forget that. Very important point. And as a general management, you need to remember in atrial fibrillation, two things are important: rate control and then rhythm control. Rate control is the question also. What is that I told you? It is a beta blockers. That is very important for rate control, controlling the heart rate. That is why the answer also was beta blocker only, right? Now, equally important is to control the rhythm. And for controlling the rhythm, you need to know two things: whether the patient is hemodynamically stable patient or the patient is hemodynamically unstable. The quick way of looking at it is blood pressure. In your exams, the clue will be given like this: blood pressure. Blood pressure is okay, we say that the patient is stable. Blood pressure is low, we say the patient is unstable. Like that, clues will be given. But anyway, in our question, it was already given the patient is stable only. Anyway, it's okay. Tell me, if it is a stable patient, I will use a drug. I will use drugs. Can you tell me what are the common drugs useful in the management of this condition to control the rhythm? Okay, amiodarone. Any other drug? Flecainide, dibutylide. So many drugs are there, right? These are the common drugs which are useful for controlling the rhythm in this patient, provided the patient is stable. But tell me the big question: if the patient is unstable, can you use any drugs? No. You have to provide what? Unstable patient, what are you going to provide? You are going to provide shock. You are going to provide shock, and that is what we call it as cardioversion. Cardioversion. Shock should be provided. That is what. Okay, right? So for rhythm control, you should look at the hemodynamic status of the patient. That is what I am trying to say, right? Fine. So anyway, the clear answer for this question, it was asking about the rate control only. So for rate control, I'll go for beta blockers. That was question number 23, which is now completed. Okay, right. Now let's move on to the question number 24. Yes. A 55-year-old male with a history of cigarette smoking and hypertension presents to the emergency with sudden onset crushing substernal pain that began 45 minutes ago. The pain radiates to his left shoulder and it is associated with diaphoresis, that is sweating and nausea. Tell me, what is this description for? Substernal chest pain, which is of crushing nature, very important clue, and also the pain is radiating to the left side of the shoulder. What is that pain? Is it something related to the heart or not? Definitely it is something related to the heart. It is angina. It is the anginal pain. Okay, it is the angina pain. That is what I am trying to say, right? It is the angina pain. That's what you need to remember. It's an angina pain. On examination, he appears to be distressed. That is okay. His blood pressure is 110/70. That's also okay. Heart rate is increased 105. Oxygen saturation is normal 96%. The ECG shown in the image below is obtained immediately upon arrival of this patient. Okay, right? This is where our main clue is lying. Tell me, based on this, what is your diagnosis? Yes, what are you able to see? I am able to see in the chest leads. Okay, right? I am able to see in the chest leads. V1, V2, V3 and V4. What I am able to see in all these leads? I am able to see ST elevation. Can you see that? All these very striking, right? All these very striking. ST elevation, or this condition is nothing but ST elevation myocardial infarction. ST elevation. And I am able to see in V1 to V4. Okay, V1 to V4, right? Anyway, this is ST elevation MI only. Now tell me, before I go to the question only, I am asking these additional questions. You can try to tell me. If it is V1 to V4, tell me which artery blockade could have resulted in this condition. Which artery blockade could have resulted in this condition? We all know artery localization can be done with the help of ECG leads. Three main arteries are LAD, left anterior descending, left circumflex artery, right anterior descending artery. I am asking, based on which leads are showing the changes, you can also decide which artery is getting affected. For example, left anterior descending. Okay, left anterior descending is supplying the anteroseptal portion of the heart. Anteroseptal portion of the heart. So tell me which leads will show the changes of ST elevation. Of course, V1 to V4, which is what we were discussing in this question also. And we all know that left anterior descending is the most commonly affected artery, right? Most commonly affected artery in myocardial infarction, right? That is number one. Can you tell me left circumflex, CX is circumflex, that is going to supply the lateral side of the heart, correct? That is going to supply the lateral side of the heart. So tell me, which leads will show the changes? V5, V6, anything else, anybody? Lead 1, limb lead, as well as the augmented lead AVL, AVL. Don't forget, okay? AVL, okay? You can just remember like this, L for lateral, L for that AVL also, you can try to remember, okay? Tell me, right anterior descending supplies which portion of the heart? It supplies the inferior portion of the heart. That is why we call it inferior wall MI. Tell me, which leads will show changes if it is inferior wall MI? Inferior wall MI. It is lead 2, that is the limb leads I am talking about, lead 3 as well as AVF. AVF. This is important. Remember like this, inferior F and AVF like that, you can try to remember. Okay, right? This is very important. Based on what based on what leads are showing the changes, we can also say which artery is affected in that particular patient, right? Okay, fine. Anyway, getting back to our question, I was concluding that it is ST elevation MI related to V1 to V4. V1 to V4 means what is the artery that is affected? Definitely left anterior descending artery. Occlusion has caused MI in this patient. Now the question is, which is the most appropriate step in management of this patient? Which is the most appropriate step in the management of this patient? Is it starting intravenous heparin and admit to the telemetry unit for observation or intensive care unit for observation? Perform urgent coronary angiography and percutaneous intervention, that is PCI, or administer nitroglycerin and wait for the cardiac enzymes results, or discharge the patient with oral aspirin and schedule and stress testing for that patient? Which one do you think should be the best answer for this question? Best answer. Here and all, you should not think much, right? It's a very straightforward question. ST elevation MI means what is the treatment you're going to give? Of course, I have to reperfuse. I have to do reperfusion, and for reperfusion, I have to perform an immediate angiography and do percutaneous intervention. No doubt about it. Look at the other option. They are not even fitting into the picture. What is that? Intravenous heparin. Will you start anticoagulants and wait? No, nobody is going to do that in this situation, right? So that is going to be out. Then administer sublingual nitroglycerin. That is correct only. But will you wait for the enzyme results and then take any decision? No. Please remember, the faster you act, the better it is for the patient, or you are going to save the patient in a better way. You don't wait for the cardiac enzyme result to see whether they are elevated or not. This is absolutely wrong. Nobody is going to discharge this patient on oral aspirin, right? Because he is having an emergency. Nobody is going to do that. So anyway, option D is a clear answer for this question. I will just quickly take you through the management aspects of ST elevation MI. First and foremost thing you need to remember is the initial management, right? The patient comes to the hospital. What are the immediate things you are going to do? All of you know about this. We need to do antiplatelet treatment, right? Antiplatelet, what is that? Aspirin should be given. Along with that, what is antiplatelet? Yes, the clopidogrel or the ticagrelor should be given. What is that actually? It is P2Y platelet, what is that? Platelet receptor inhibitor, right? P2Y antiplatelets. Okay, it's always dual antiplatelets which is recommended, not just aspirin. Aspirin along with clopidogrel or ticagrelor. Okay, right? The ticagrelor should be given. So it's always dual antiplatelet which should be done. Can you tell me what else you are going to do? Oxygen should be given to keep the SpO2 to more than 92 percentage. You have to give oxygen, no doubt about it. Then nitrates, of course, what I'm talking about, nitroglycerin should be given sublingually. That should be given. These are all immediate things you are going to do, right? Then beta blockers, very, very important. Every patient with myocardial infarction, you have to control the heart rate with beta blocker, because it is said that there can be ventricular arrhythmias which can be precipitated if the heart rate remains high. So you should give beta blockers for every patient unless there are some contraindication, right? Generally, beta blockers are indicated. And these are all like immediate or initial management you are going to do. But only one important caution I want you to remember here is, in inferior wall MI, you should avoid nitrates. Okay, you should avoid nitrates. Can anybody tell me why in inferior wall MI you have to avoid nitrates? Anybody? Why inferior wall MI you have to avoid nitrates? Remember, inferior wall MI means which side of the heart is affected? Right side of the heart is affected. Right side heart is affected. Basically, what happens is, if you give nitrates, what will happen? Nitrates will decrease the preload on the heart, or in other words, they will decrease the venous return to the heart. So what happens? Heart can't even push out the blood also properly, right? It becomes like a passive structure, right? It decreases the preload on the heart. So that is why always if it is inferior wall MI, we need to completely avoid nitrates. So now tell me, in inferior wall MI, to improve the preload, what should be one of the things you will always give for the patient? That was this January exam question also. To improve the preload for inferior wall MI patient, what should be one of the important management? You should give IV fluids, intravenous fluid. That only will improve the preload and is recommended for every patient with inferior wall MI. Please don't forget, this is a recent, very, very recent PYQ asked in this January exam. Okay, right? So please don't forget this. Okay, fine? Yes, correct. That is what. These are all initial things which you need to remember. But if somebody asks you the question, what is the best intervention? What is the best intervention for ST elevation MI? This is what I want you to remember. This picture is extremely important, right? So many important things are there. I already told you PCI, angiography and PCI should be done as early as possible. Very, very important, as early as possible. What is the timeline I have written? Within 120 minutes. Within 120 minutes, you have to perform percutaneous intervention. Okay, right? Or at least you have to shift the patient to a hospital which can perform percutaneous intervention. Suppose the hospital cannot perform percutaneous intervention, then what is the next best option? The next best option is to perform thrombolysis, like alteplase, retiplase has to be given, right? So very important, best is always PCI, percutaneous intervention. If that is not possible, then you can go for thrombolysis. That is what I'm trying to say, right? So this is like a, the definitive intervention which we have to give for patient with ST elevation MI. Don't forget that important number. It should be performed within 120 minutes, right? That is what you need to remember, right? Within 120 minutes, right? All these are, this is like a very important, timeline which is often asked in your exams also. So you should know about it. That's it. So anyway, the clear answer for this question is going to be option B only. Perform angiography and percutaneous intervention as soon as possible. That's it. Okay, right? Or at least within 120 minutes you have to do that. That's it. So that is about our question number 24. That brings us to our last question for discussion today. That is about a statement type of question regarding acute rheumatic fever. Okay, acute rheumatic fever. I'll take up one question which you had asked. If the patient is stable like no other comorbidities but had non-ST elevation MI, then how long we have to give anticoagulant and aspirin? See, anticoagulant and aspirin. See, initially we will give a dual antiplatelet only, and then once you're discharging the patient, you will continue on long-term aspirin, right? That is what you need to give for patient with non-ST elevation MI. Okay, fine. Right. Now let us see this question. Which of the following is correct regarding acute rheumatic fever? It's a statement type of question. We all know that acute rheumatic fever, it's a post streptococcal condition, correct? It's a post streptococcal condition, correct? Question is which is correct regarding this condition, that's what. Acute cases can present with aortic valve rupture. It happens 2 weeks after group B streptococcus infection. Myocarditis occurs but not endocarditis. Ash of bodies are seen. Let us take the options one after another, right? I am not going to discuss much. I am just going to discuss the question only. It's one of your PYQs related question. That is why. Let's look at the option one after another. Number one, acute. First option was acute cases can present with aortic valve rupture. Is it true? No, it is wrong because the most commonly affected valve in case of acute rheumatic fever, what is that? Is it an aortic valve? No, it is mitral valve. Okay, right? Mitral valve is the most commonly affected valve. So that is why the option A is wrong. That's it. Option B, it happens 2 weeks after group B streptococcus infection. 2 weeks is correct only after streptococcus infection. But is it group B streptococcus infection? No. What is that? It is group A beta hemolytic streptococci. Very important. Group A beta hemolytic streptococci, right? That is why the second option is also wrong. It is not group B, instead it is group A. Then myocarditis occurs but not endocarditis. That is also wrong. Why? Because the type of cardiac involvement which occurs in rheumatic fever is pancarditis. Pancarditis. Pancarditis means what? All layers of the heart are affected. That is endocardium, myocardium, as well as pericardium is affected. Okay, so saying not endocarditis is actually wrong. That is what I am trying to say. So what is the correct option? It is ash of bodies definitely are seen, and that is supposed to be one of the hallmark features of acute rheumatic fever. I think all of you should know about this. And what is that ash of body? It is more of a pathology question only, but still you can make a note of it. What is that? It is something like an area of necrosis, okay, inside the myocardium or endocardium, like that, and that is characterized by this ash of body, and that too some special type of macrophages you are able to see. Some special type of macrophages you are able to see. Any of you know what is this name for this macrophages? Okay, the entire area of necrosis is called ash of body, but what is this type of macrophage called as? It's called Anishkov cells. Anishkov cells. And if you see, it is nothing but a macrophage only, but it's like a special type of macrophage where you can see the structure of the nucleus. Can you see that? It is something like this. The nuclear chromatin is arranged like this. The nuclear chromatin is arranged like this. Nuclear chromatin is arranged like this. And this is what we call it as, yes, what do you call it as? Caterpillar cell, caterpillar arrangement. It's something looking like a caterpillar. That is what we call caterpillar-like arrangement of the nuclear chromatin. Okay, I do agree that it is seen in postmortem once you take the biopsy only, but still, the question was asking, it's more of not a clinical question only, doctor. It is a clinical and pathology related question. Together they have asked. Anyway, ash of body is the pathological hallmark of rheumatic fever, and it is characterized by the caterpillar appearance of nuclear chromatin, which is what we call the Anishkov cells. Okay, right? Are you able to follow this? Yes. So anyway, the clear answer for this question is going to be option, sorry, not C, I'm sorry. The clear answer for this question, I'll mark it here only, okay, right? It is ash of bodies are seen is correct statement regarding acute rheumatic fever. That's it. Is it clear? Okay, so that was about our final question for discussion in this 25 most important question, which I feel are important for your upcoming exams. Okay, right. So I hope all of you had some quick revision of the important topics in the medicine section, which I tried to cover in this 25 questions. Okay, and hope it will be helpful. Please do revise your notes. See the last 4 years of PYQs or 5 years of PYQs thoroughly, and don't skip any part of medicine because good number of questions are definitely expected in your exams. Okay, right. So with this note, I would like to end the discussion today, and I wish you all the best for the upcoming exam. Thank you.